to me, there seems to be a lot of uncertainty out there. Nevertheless, we all are trying to cope with all the difficult situations. And we have found some good things in spite of all these difficulties. Our webinars, for instance, true, it helps us tap into a larger pool of expertise, but it is quite challenging for us hosts. We have to keep the attention focused of all our participants from the beginning till the very end, in spite of distractions at their home and work front. The Noida Obs and Gynae Society we have successfully organized annual CMEs and even the North Zone FOGSI in the year 2019. Today for you, we have a mixed bag of sorts, the Gynae Cancer Screening Month. Now, before I give you a brief outlay of the program, it's a proud privilege to welcome a doyen, a living legend, who was confirmed the Knight Bachelor by none other than Her Majesty the Queen for his exemplary work in the field of medicine. Professor Emeritus Sir Sabaratnam Arulkumaran. We are truly honored, sir, you so graciously accepting to deliver the oration at our annual CME today. I would also like to welcome our other distinguished speakers, the dynamic Dr. Pratap, the vibrant speakers, Dr. Umaram, Dr. Akshata Sharma, and Dr. Anbu Subayan, who will be touching upon very thought-provoking topics. And of course, the power-packed panel discussion, which is going to be moderated by Dr. Arul Mori and her lively, enthusiastic panelists, Dr. Shaijas, Dr. Nizat, Dr. Tejavati, Dr. Jyoti Bhaskar. Dr. Arul Mori will be touching upon clinical case scenarios, situations which no practicing obstetrician would like to face. And of course, she will be giving us a take-home message after each of the difficult clinical case discussion. I would like to welcome our esteemed chairpersons, without whose academic input, no CME is complete. And most of all, our participants. Thank you for taking time out from your busy schedules, for being here with us today. We have valuable content and we hope you enjoy the CME and hope you'd have something to take away from every talk. There is a question and answer box at the bottom of your screen. And if you have any questions, just pop them in there. It will be answered right there in the box or at the end of the session. Now, without much ado, I would hand over to the moderators of session 1 to kickstart our program.
Thank you, Dr. Sujata, for giving an elaborate insight and a welcome address to all the esteemed faculty whom we are having at our bay today. And we are going to be richer academically with all their knowledge and their wiseness. Without wasting much amount of time, can we move ahead to call upon our first set of chairpersons? For the first set, we have got esteemed faculty, Dr. Mala Arora. Mala Arora, ma'am, she is been the chairperson. She has been the chairperson of ICOG in 2017. She was a past vice president of FOGSI in 2011, editor of Yearbook 2018, chief editor for recurrent pregnancy loss in 2013, 2003, 7, and 2018. And chief editor of World Clinics in Obstetrics and Gynecology, Volume 1 and 10. Editor-in-chief of Yearbook in Obs Gynae 2018, 19, and 20. She is the chief editor of, for the first trimester of pregnancy, hyperhomocystinemia, associate editor, International Journal of Infertility and Fetal Medicine, peer reviewer of British Journal of Obs and Gynae. Can we have the next slide, please? Can we introduce the next chairperson? We have got Dr. Krishnendu Gupta, who is also the past ICOG president of FOGSI and professor and head of the department at Vivekananda Institute of Medical Sciences. One second. Adjunct Professor in the Department of OB-GYN at Kasturba Medical College, Mahe, Manipal, 2017 to 2022. Chairperson for the Sexual Reproductive Health Committee Medicine and Asia Oceanic Federation of Obs and Gynecology, FOG, from 2019 to 2022. FOGSI representative to FOG from 2020 to 2021, Chairperson of ICOG 2016, President of Bengal Obs and Gynae Society in 2013, Vice President of Federation of Obs and Gynecological Society and in 2011, and President of ISOPAB Kolkata Chapter 2015 to 2019. Chairperson of Reproductive Endocrinology Committee of FOGSI 2003 to 2007, and National Corresponding Editor of Journal of Obs and Gynae Jogi, which is from 2014 to 16. And he's got a vast experience. I now hand over formally to Dr. Anshu to kindly introduce the rest two chairpersons.
Thank you, Dr. Raki. Now I would like to invite our rest two chairpersons. And our next chairperson is Dr. Suvarna S. Khadikar, ma'am. And she is a professor and head of the department and consultant endocrinologist and gynecologist, Bombay Hospital Institute of Medical Sciences, Medical Research Center, Mumbai. She is at present a treasurer of FOGSI 2018-21, and she was a joint treasurer between a period of 2015 to 18. Ma'am was a joint secretary of NOGS 2020 and more than 21 international and national index publications, author of over 50 research papers, 29 awards for the research of international and the national level, and Young Scientist Award in Dr. Kumod P. Tamakar Research Prizes and Dr. C.S. Dawn Prize in 2000. Ma'am is the editor of 12 books, Endocrinology in Obstetrics and Gynecology, and 1000 MCQ on menopause. And please welcome Ma'am Dr. Suvarna. So next slide. So our next chairperson is Sir Dr. Bhaskar Pal, and he is the Honorable General Secretary, Indian Association of Gynecology Endoscopists in 2019-20. He is a chair of AICS RCOG East Zone and chair-elect of AICC RCOG, FOGSI representative of CEPHOG 21-23, President-elect Bengal Obstetric and Gynae Society, Vice President FOGSI 2017, and ex-honorable biostatistician of Obs and Gynae Journal of India. Please, sir, please.
Thank you, Anshu.
Now, I would like to request our all chairpersons to please start the session with the first speaker. Thank you.
So, thank you, Noida Obs and Gynae Society, Raki, Sujata, and everybody for inviting us. It is my great pleasure to invite for the first talk a very dear friend and a very accomplished obstetrician, Dr. Uma Ram. She has been the chairperson, or she's currently also the chairperson of South Zone AICC RCOG. She's an examiner for Part 3 MRCOG and a coordinator for Part 2 and 3 MRCOG courses in Chennai from 2003 to 18. She has contributed many chapters, edited many books, and has many publications. She has also received the Young Gynecologist Award 2007 in AOFOG and the IDF Blue Ring Women Achiever Award by Rotary International in 2015. She's going to deliberate today on a topic which is of extreme importance: unexplained stillbirths. Are they really unexplained? We are eagerly waiting, Uma. Over to you.
Thank you very much, Mala, for that kind introduction, and thank you, Sujata, Raki, Anshu, and the entire Noida team for this invitation. I've been asked to talk about a rather challenging topic. Now, stillbirth is a challenging condition for all of us who practice obstetrics, but stillbirth is also a challenge for the world at large, and it is a public health issue. And in India, even though we don't figure among the 10 highest countries with stillbirth rates, simply because of our large number of births, we have the highest number of stillbirths. And therefore, both in a national level and at a personal level for the obstetrician, and certainly for the couple who experience it, an intrauterine fetal demise is a challenging and a very difficult problem. Now, there are different definitions of stillbirth. The WHO definition of stillbirth coincides with the ICD definition of late fetal demise, which is a birth weight of more than 1,000 grams, or if that's missing, greater than 28 completed weeks, or if even that is missing, a body length that's greater than 35 centimeters. Now, what is unexplained stillbirth? It's defined as a fetal death that cannot be attributed to an identifiable fetal, placental, maternal, or obstetric etiology due to lack of sufficient information, or because the cause cannot be determined by the current level of diagnostic ability. And these two factors actually will either increase or decrease the number of stillbirths that we label as unexplained, the lack of information and the diagnostic ability. And roughly 25 to 60% of stillbirths, and that's quite a large range, can get classified as unexplained. Now let's look at some clinical situations. We have a low risk primary, the baby is growing well, she has no medical problems, she's had a scan at 36 weeks where the growth is reported to be normal, and yet there isn't a heartbeat that can be located at 40 weeks. We will call this an unexplained stillbirth at the point where we are making a diagnosis. And we move on to another situation where there is a second para 2. She's had one normal birth. She has well-controlled hypertension on very minimal medication. The baby is growing on the 20th centile. No evidence of any preeclampsia, no gestational diabetes, but at 34 weeks, there is a stillbirth. Now, this is another situation. We have a 25-year-old primary. She's just been married 10 months, but at booking, her sugars are found to be high. Clearly a pre-existing diabetic, which was not diagnosed. But after counseling and initiation of insulin, her sugars were under reasonable control, though her fasting was occasionally in the region of 95 to 100. She had a target scan where the baby was found to be normal. Growth is actually plotted and found to be growing normally. And at 37 weeks, she's reviewed. We asked her, we've done a CTG, we've looked at the fluid, and we set her up for induction 4 days later. When she comes in for induction, we are not able to localize the heart. I mean, I'm sure all of us have been in this situation where we feel this constriction in our chest, because at that moment, we really don't know what to give as the explanation for this demise. She had a 2.8 kilo baby, so there was no macrosomia. There was no structural abnormality. She delivered vaginally. So how do we, is the cause of this her diabetes? Or is it really unexplained because we actually managed to control the diabetes fairly early? What about somebody who has cholestasis of pregnancy, elevation of bile acids, but a normal liver function test, normal fetal growth up to 34 weeks, and then a stillbirth at 36 weeks? Again, are we going to say this stillbirth is purely because of cholestasis, or is there something more? So the fact is that there is a variation in the rate of unexplained stillbirth based upon the population that we're looking at, based upon whether a complete evaluation of the stillbirth has been done, what classification system has been used, or has there been a subjective interpretation of the problem? Because many times, like in these 3 or 4 clinical situations that I have just discussed, there can be an association. We know that there is an association with diabetes and stillbirth, with cholestasis and stillbirth. But what actually caused the stillbirth in this woman is something that we need to identify, and this requires investigation, because otherwise we may assume that the cholestasis caused the stillbirth when actually something else was at play which we failed to identify. So what are these classification systems? There have been different types of classification systems that have been in use, and a discrete cause is not identified in more than half the cases. And this was an interesting study where they looked at 4 systems of stillbirth classification applied to the same cohort of 154 stillbirths in Italy, and they used the Recode, Tulip, Gallant-Rosen, and the Wigglesworth, and the cause was identified in a varying proportion between 53 and 84 to 86. Now, when we do a detailed dysmorphology and a complete placental study, in 50 to 60% of cases that were labeled as unexplained, a cause was actually identified. Now, this is a Wisconsin stillbirth service program that looked at a community-based approach to stillbirth. And here they gave an increased emphasis on placental studies and shifted the thought process from saying there is one single cause to multiple contributing factors. And in this, they found that about 95% of stillbirths had at least one identified cause, but nearly 70% had more than one cause. And this was picked up only because of a detailed diagnosis. And this is the WISP protocol, where they actually go back and look at a history, including a detailed family history, and then a clinical examination, a taking of a photo and an X-ray, and then taking permission for autopsy, which is a challenge, and it has to be done with a great degree of sensitivity at a point where the couple are in shock and grief. But if they do consent to an autopsy, then that can be done. If not, at least an X-ray, and or a limited autopsy, which I will come to later, or at least a placental examination, and then a lot of laboratory tests, including a Clay-Hodgkin, which many of us will find a challenge to do because we just don't have the labs which do it. And then all of this is evaluated by the WISP geneticist, and then a specific cause was found in nearly 70% of cases. And if we look at why stillbirths happen, there is a long list of cases that are there in different forums. We know that these are the babies which are more at risk when there's growth restriction, infection, congenital abnormalities, or when there is maternal disease. But like I said, while we may visibly see a single factor which is operational, there may be more than one which is acting, and placental histopathology and autopsy will contribute significantly to help us identify the cause of stillbirth. Now, therefore, autopsy and placental studies have to be offered to all stillbirths, and this can directly change the management of the subsequent pregnancy, and the histological findings may also help us identify the time of fetal death. If there is, consent is not given, we can, where we have the opportunity, talk about restricted autopsy or a minimally invasive autopsy. Again, I realize that many of this is not possible in large practice situations, but at least a placental examination and a histopathological examination, because you can get useful information contributing to the cause of death, and where it is appropriate, maybe we need to build capacity to do at least directed needle biopsy so that we can get some tissue which can then be studied later. Now, I just want to present one situation highlighting the importance of autopsy and targeted mutation, and I'd like to acknowledge the perinatal pathology department of Mediscan Systems. This was a case that was referred for small for gestational age in the 3rd trimester. Growth was actually normal, but the unilateral renal agenesis was picked up. And you can see it was a small baby, but not growth restricted. And at full term, there was an intrauterine fetal demise. Autopsy was counseled, and they saw at autopsy that there was a syndactyly of the toes, there was cryptophthalmos, and a unilateral renal genesis. So they suspected Fraser syndrome and counseled the couple for additional testing, but the couple declined. They came back 2 years later for a 12-week scan, but because this detail was available, even at 12 weeks, there was, the limbs were looked at fairly carefully, syndactyly was picked up, the absence of kidneys was picked up, and then there was a counseling done for CVS and targeted mutation analysis, and it was found that the fetus indeed had a FRAS mutation coded for Fraser syndrome. Then the parental karyotyping, parental testing was done, and the father did have a copy of the condition. So this completely changes the way we can potentially counsel, including talking to them about risk of recurrence and what options they will have in these kind of genetic concerns. Just doing a karyotypic analysis may not be enough because it will underestimate And in many cases, especially if we take out placental biopsies after the demise, the expulsion of the fetus and the placenta, very often cultures are not successful. And therefore, there have been papers which have recommended that if we want a higher yield, we can actually do an amniocentesis before delivery. This can increase the yield from 28 to 85%. And that is something that we may want to think about when we are counseling. And offer microarray, because it's more likely to identify genetic problems over karyotyping. But again, this is expensive and it is not yet part of routine stillbirth protocols. Now, if you ask me what is the rate limiting step in the evaluation of a stillbirth, my answer would be the perinatal pathologist, because we simply do not have enough perinatal pathologists in the country to be able to do that level of analysis and guide us as to what to do going forward. And that is a capacity building that probably as a community and we need to start thinking about, because a lot of the answers are going to come from these people. So the evaluation of stillbirth protocol involves a detailed maternal history, taking the fetal weight, length, sex, and head circumference, understanding that weight may be different from what we weigh in the labor room and what the pathologist weighs, take photographs, document the findings, consent for autopsy, and if no autopsy, at least a placental HPE. Maternal testing would include doing a Kleihor-Betke, a complete blood count, an infection screen when relevant, where relevant, a urine screening for toxicology, screen again for diabetes even if it has been done before, and do an antiphospholipid screen, and repeat that after 6 weeks if the result is negative. Cytological specimens to be sent off. This is from the ACOG practice guidelines, where they give you a list of what are all the samples that need to be taken and sent in the event of a stillbirth. Now, it's important for us to subsequently review the case, document, and put down what it is that we are thinking about. Because as an obstetrician, when we are faced with an intrauterine fetal demise, we are equally troubled as the couple. And therefore, sometimes certain things may not strike us. So it's important to sit back and look and review this case sheet, review the woman's details with her reports and interpret it again once we get all the reports back from the perinatal pathology or the genetics or the autopsy, and then put down a plan for the next pregnancy, because she may not come back to us, but wherever she goes, they need to have all the information in order to ensure that she has a viable, healthy baby the next time. So are unexplained stillbirth really not explained? The answer to the question is yes, sometimes they are unexplained when they are first diagnosed. In fact, many are unexplained when first diagnosed. But if we do a detailed and good quality evaluation, then we can minimize the number that are labeled as unexplained, and the identification of the cause will help us achieve a live birth the next time. Thank you very much for your patience.
Thank you very much, Dr. Uma, for that wonderful presentation. I think, I'm sure for a lot of the practicing obstetricians who are watching this webinar, it will be a great learning experience for them. And of course, for the postgraduates, it's going to be even wonderful. It's my pleasure to introduce Dr. Akshata Sharma. Can I have her slide, please? Well, Dr. Akshata Sharma is a consultant in fetal medicine at the Apollo Center for Fetal Medicine, Indraprastha Hospitals, New Delhi. She's a national examiner of the FMF UK Anomaly Certification Program, the member of the RCOG of UK, the treasurer of the Fetal Medicine Foundation of India, and the member of the Society of Fetal Medicine, the Society for Fetal Medicine, and a member of FOGSI. Well, the awards that she has received with the Commonwealth Scholarship for Fetal Medicine in 2014, the best paper for the INSWOG International Symposium in New Delhi in 2012. She has a number of publications. She's a research fellow for the multinational WHO project of the All Institute of Medical Sciences, the WHO Fetal Growth Charts, which is a multinational longitudinal study of ultrasound biometric measurements and estimated fetal weight. And of course, as I mentioned earlier, she has numerous publications in the peer-reviewed journals. So we are all waiting to hear Dr. Akshata Sharma, who will be actually speaking on what is the vision of the fetal medicine through the obstetrician's eyes. So it's titled Obstetrician's Eyes, Fetal Medicine Vision. Dr. Akshata Sharma, please.
Thank you very much for the kind introduction, and I take this opportunity to thank the NOGS for holding such an excellent program. And I see that we are on time, we're working in time, and I hope to keep up to the time that is scheduled. Is everyone able to see my screen?
Yes.
Yeah. Thank you. So as we know, the distance from the obstetrician to a healthy pregnancy, in the journey towards this, we do have multidisciplinary approaches that come in, and one of the important ones becomes when the fetal medicine person looks at the pregnancy from the obstetrician's point of view, and then the obstetrician looks at the pregnancy from a fetal medicine point of view. And these are just a few case-based scenarios to that effect. So without wasting any time, I'll just begin with my case 1. This was the Gravida 3 Para 2 living 2, 41 years old, first degree consanguinity. The first child was reported to have mild clumsiness in walking and had mildly delayed milestones. The second child was absolutely normal. So this was her third pregnancy. She was previous to LSCS. And the first trimester scan done elsewhere was reported to be normal. So the astute obstetrician looked at the clinical history and she referred her to us because of these factors. One, she was 41 years old. There was first degree consanguinity, and there was something amiss in the first child. So when the couple came to us and we had a look at the child, there was difficulty in walking. So they gave us a history of a tendon release surgery for a CTED. A mild obesity was seen. Neurodevelopmentally, the child could interact with us. However, there was mild neurodevelopmental delay in the sense it was studying, the son was studying in a class less than the usual age. And the other thing that we noticed was this removal of a skin tag. This was not a history that was, this was not something that they told us, but we could see the skin tag that was removed that gave us a clue that this was probably a post-axial polydactyly. A clinical geneticist's opinion was taken, and this was suspected to be what is called as a celiopathy, and a clinical exome sequencing for this index child was sent when this pregnancy was at 12 weeks. We called her back for an early anomaly scan. For an early anomaly scan, the growth was absolutely normal. And if you see here clearly, you can see this leg that is interned, and there is this 6th digit that you can see. So this was a post-axial polydactyly. If you looked at the kidneys were mildly echogenic. However, we knew that we had one such case prior to this. So we did offer an amniocentesis even before the previous report was out. So technically, when you send a clinical exome sequence, it takes about 4 weeks for the reports to come. So she was about 17 plus 2, and we were expecting the reports of the clinical exome. However, we went ahead with an amniocentesis, and like we expected, this pregnancy was also affected. This pregnancy and the previous pregnancy both were affected with a Bardet-Biedl syndrome. It was a likely pathogenic variant for Bardet-Biedl syndrome. Now, Bardet-Biedl syndrome has exactly the same features that were seen in our index child: obesity, polydactyly, retinal dystrophy, all of which was seen in our case. And this had an inheritance of autosomal recessive inheritance, which meant that there was a 25% chance of recurrence in every pregnancy. So the take-home points here were that irrespective of the family history, even if she's had a subsequent normal pregnancy, the presence of any delayed milestones must be investigated, especially in the background of consanguinity. there has to be an early referral and preconceptional counseling for these patients. So luckily for us, because she came to us at 12 weeks, because she was referred to us at 12 weeks, we were able to counsel and conduct the tests so that before 20 weeks, which is the legal limit in India, we were able to give her an answer. And the pregnancy, she was the previous 2 cesareans, so the pregnancy could be terminated well in time without additional risk for the mother. So all these things just tell us how important the obstetrician's role is in diagnosing genetic disorders as these early. So a similar case, moving forward to a similar history that we came to, this was a case 2, she was a gravida 3 para 2 living 2. She came to us for a second opinion scan in 2018 at 19 weeks. She gave a history of termination at 20 weeks for some heart defect. There were no details available. When she came to us in the second pregnancy in 2018, this was how the heart looked. I have kept a normal heart for reference. So if you look at this heart, the striking features are that it is looking very echogenic. All the chambers are looking quite echogenic, and that it is moving quite slowly. The fetal heart rate was just 50 beats per minute and poorly contractile heart. So 2 things we knew. There was one, a complete heart block, and there was myocardial injury for some reason. The endothelium looked quite bright. She did not give any history of any medical disorders. However, we, on eliciting further, asking certain targeted questions, she said she did have occasional joint pains, and we advised an ANA that came out to be positive, and further on an anti-Ro-anti-La antibodies that was positive. Now, in this case, they opted for termination of pregnancy because they knew that the baby would require a pacemaker after 20 weeks. With such poorly contractile heart, they would either end up in an IUFD or hydrox, leading to an IUFD, and so they terminated this pregnancy. We called her back for a preconceptional counseling, and we explained to her that the presence of anti-Ro anti-La would mean that every pregnancy she has a chance wherein the anti-Ro antibody could go and affect the SA node, and that could cause the congenital heart blocks. So the incidence in primary gravida is only 2%. However, it increases with the previous affected child to nearing 20%. So we did a detailed rheumatological workup. She was diagnosed as SLE. All the other antibodies were negative. There was no APLA antibodies, as there could be an association of APLA antibodies. They could all occur together. So the plan of management was made for her for the next pregnancy, wherein we decided for a viability scan, followed by starting her HCQS at 12 weeks, followed by PR interval monitoring throughout the pregnancy. So the rationale for screening is that once the heart block has occurred, it is irreversible. We can't do anything about it. However, we have certain protocols where if you find first degree heart block, we can start dexamethasone. If you find second degree heart block, we can consider IVIG, and so on and so forth. And so she came back to us in her current pregnancy, which is the 3rd pregnancy. So we did a viability scan. HCQS was started at 12 weeks. And currently the pregnancy is at 31 weeks. We are monitoring her with PR interval, and there are no signs of heart block, and we expect a normal outcome in this pregnancy. So the take-home points here are that there are implications of maternal disease on the fetus, and sometimes these maternal diseases are unearthed only after we see a fetal problem. So the obstetrician and the fetal medicine person must work in tandem to look at the history so that we initiate these prophylactic therapies that can alter the course of pregnancy. So moving on to case number 3. Now this was a gravida 2 para 1 living 0. The previous child had intraventricular hemorrhage at term and had a neonatal death subsequently at day 10. She came to us for her current pregnancy for a routine antenatal scan. Now, whenever we hear intraventricular hemorrhage, it's not the most common thing that you hear in a fetus. The intraventricular hemorrhage, the incidence is just about 1 in 10,000. So we are always concerned, and we have a protocol for history taking in such cases. So we asked about, maternal thrombocytopenia, neonatal thrombocytopenia. We went through the discharge summaries of the neonate, and the positive history here was that the neonate did have thrombocytopenia. So now we were concerned, why was there thrombocytopenia? Was this thrombocytopenia because during the clotting process postnatally, was it used up? Or could there be something else? Was there any maternal antibodies that are causing decrease in the platelets? So like we have an RH where we do an ICT, similarly here we have screening for platelet antibodies. And it was found that the mother had platelet antibodies. Now, the platelet has certain antigens, and the clinically relevant antigens are about 5 or 6 of them. And it was found that there was incompatibility between the husband and wife at HPA1 and HPA5. These two loci, the husband and wife, are incompatible. The fetus was tested. The fetus was incompatible with the mother as well. So what would happen here? The fetus is HPA1A positive. The mother is negative. So if there is a mixing of the blood, there would be an immune reaction. And just like in RH, where the RBCs are destroyed, here the platelets would be destroyed. And this would cause bleeding in the neural tissues, causing disability or death, which meant that this pregnancy was again at high risk for having intraventricular hemorrhage. And the mother was started on IVIG based on the algorithm that we follow. And so at 24 weeks, we could see that there was mild asymmetry in the ventricles. However, no particular bleeding was seen. We kept looking at her at our neuroclinic that we have in our unit, but the ventricles remained stable over serial scans, and the pregnancy, and she delivered at 36 plus 4 weeks with a baby boy who did well. So this pregnancy was uneventful for her. So there has to be a detailed investigation. So the take-home points here, detailed investigations of the previous loss, which would mean even contacting the previous doctor where she delivered with, and knowledge of rare fetal pathology should be there, and FNAIT or the fetal neonatal alloimmune thrombocytopenia is a preventable cause, and appropriate therapy can be looked at. Now this is my last case, case number 4. This was a primary gravida at 34 weeks and 5 days. This was an IVF conceived DCDA twin pregnancy. She was admitted in emergency at another hospital with complaints of excessive pain and vomiting. With a suspicion of DVT, she was shifted to Apollo for her further management. The maternal study turned out to be normal. There was no, the DVT was ruled out. From the fetal point of view, when we took the history, there was the previous aneuploidy screening was normal, and a scan done just last week was absolutely fine. So when we looked at the babies, there was mild discrepancy in the growth between twin A and twin B. However, what caught our eye was one of the twins, twin 1, had a left-right discrepancy of the heart. If you look at the chambers, the left side looks a little smaller than the right side, the ventricles. And there was mild ascites that we saw. In the heart, we could see that there was severe regurgitation. And if you looked at the ductus venosus blood flow, it was spiking. There was increased resistance. However, this was a confusing situation because the umbilical artery Dopplers were absolutely normal. The babies were growing fine. So what was it that was causing this stress on the baby? So the first thing was, could it be a coarctation of aorta, which there is a left-right discrepancy of the heart? But this was sudden. It wasn't there in the previous scans. So could this be, why is there a sudden cardiac decompensation? Could this be a ductus arteriosus constriction that could cause this? So a detailed fetal echo was done. There was restriction in the ductus venosus flow, and this was confirmed because of a typical waveform that these premature ductal constrictions showed. The twin B fetal echo was normal. An emergency cesarean section was done in view of twin A showing DV changes, moderate TR with RV dysfunction. Both babies were born with Apgars of 8 and 9. A postnatal echo showed a mild TR. However, there was no PDA flow, which meant that there was indeed a ductal constriction. Twin 2 fetal postnatal echo was fine. And when we reviewed the history from the patient, on admission in emergency, where she was admitted previously, there was a history of injection diclofenac that was given to decrease the pain. That was 2 days ago. Now, how do NSAIDs affect the fetuses? Now, you know that there is, for the fetal circulation, there's a conduit between the pulmonary and the aortic circulation, which is the PDA, the patent ductus arteriosus. And the physiological fetal circulation requires patency of the ductus arteriosus. And this artery is a muscular artery, very sensitive to drugs, whereas pulmonary and aortic arteries are elastic arteries. Locally produced PGEs usually keep this patent. However, when you give NSAIDs in the 3rd trimester, where the ductus arteriosus is now very sensitive to these vasoconstrictors, you could see that this could have caused a ductal constriction. So it has pronounced, why is the other fetus normal? Because these are like 2 different individuals, and it is possible that the metabolism in both these individuals is very different. So one twin was affected, whereas the other's ductus remained open, and luckily this was caught in time, and the baby delivered. So one must, the obstetricians here as well as the fetal medicine people, it isn't difficult to diagnose ascites, it isn't difficult to diagnose tricuspid regurgitation, but why has it happened? That is what is important for interpretation and management of the pregnancy. So knowledge of maternal drugs, not only for teratogenicity, but also when it is given in the 2nd trimester and 3rd trimester, could have effects on the fetus. So this knowledge is important. I hope that I could show how teamwork helps, and I just thought these were 4 quick cases with which we could do so. So thank you very much for your attention.
I think that was a very nice case scenario based, various abnormalities that you detected, and some of them you could even prevent and have a successful outcome. I think that is a very nice take-home message for all the obstetricians who may not be actually practicing fetal medicine, but I think these things are possible, and we can, carry out these procedures, refer to the respective specialist units for such kind of treatment. That was a very nice. Congratulations, Dr. Akshanta. It was a very nice lecture. Now we move on to the next lecture.
Hello.
Yeah. So we move on to the next lecture by Dr. Anbukani Subian, who has done a fellowship in gynae-oncology and European certification in gynae-oncology. And she's an executive committee member of Association of Gynecologic Oncologists of India, executive committee member of Association of Tamil Nadu, RCOG, consultant gynae-oncologist and robotics surgeon, Kovai Medical Center and Hospital, Coimbatore. I think the topic that she has taken is very, very interesting. I think uterine PAP, the game changer. That's a fantastic topic, and we really look forward to listening to the concepts of uterine PAP. Over to you, Doctor.
Thank you so much for having me here, ma'am. I thank Noida Society as well as the entire team, Dr. Sujata, for inviting me here among this galaxy of superstars and teachers and seniors. It's my absolute pleasure. I'm going to share my screen. So this was a very interesting topic that was put forth, and I'm really keen to share my thoughts on this. PAP-seq, is it a potential game changer in gynae cancer screening? I bring greetings from Kovai Medical Center Hospital, Coimbatore, and this month, September, is Gynae Cancer Awareness Month, and September 20th, that is tomorrow, is World Gynecology Day. So a big shout out to all the women who beaten gynae cancer, and to us healthcare professionals that are invested in helping these women out in their journey of cancer. The greatest success that social and preventive medicine has seen in terms of screening and making a dramatic change in deaths is the cervical cancer screening program, thanks to this man, Georgios Papanikolaou. Over the years, it has been seen that when pap smear is consistently done based on a call-recall system, it has a huge impact on mortality. This is just one such graph, but predominantly most Western countries have the same story, that when pap smear is done, over and over again, repetitive pap smears at the right time, it can actually have a powerful impact, and many of the Western countries have actually managed to do that. Although the story is not the same here, and most states in India do not have an organized screening program, we are still seeing that cervical cancer has shown a slight fall in the actual numbers. And you can see that the mustard block here in this pie chart from 2012 has shrunk a little bit here in the recent past. And this is more because of the actual fall in parity and delayed childbearing that women go through rather than through the screening program itself. And we still have a long way to go in terms of cervical cancer mortality reduction in our country. And it still continues to be the second most common cancer in our women. But can the same be said for ovarian cancer and endometrial cancer? Right now, on this day, at this point in time, nowhere in the world is screening for both these cancers in low-risk women and average-risk women recommended. A lot has been done because as far as ovarian cancer is concerned, even though it is not the most common gynecological cancer, it takes the largest portion or chunk of the pie as far as mortality is concerned. So ovarian cancer kills more people than cervical or endometrial cancer. So a lot of effort has been put into an effective screening method in ovarian cancers, and none of them have actually come into clinical practice as yet. This was one of the earlier trials that was done, which is the prostate, lung, colorectal, and ovarian randomized control trial published in the JCO, which utilized our annual ultrasounds and CA-125. And why I've highlighted this is even though this did not have any effect on ovarian cancer mortality, what it actually did was it had about 1,000 and odd women who underwent surgery for false positive findings on ultrasounds and CA-125, and more number of women actually experienced a serious complication because of the surgery than the number of women who actually even had ovarian cancer diagnosed. So clearly, the ultrasounds and the CA-125s that are a part of many master health check programs in our country could potentially do more harm than benefit. Then came up the mother of all trials, of all screening trials in the ovarian cancer space, which is the UK CTOX, the randomized control trial led by Professor Ian Jacobs et al. That compared 3 arms. It had no screening on one side, it had annual ultrasounds on one side, and there was a new modality called the multimodal screening. I'd like to call this personalized CA-125. So instead of having a random set cutoff of more than 35 international units, what they did was they looked at a CA-125 that was specific to a woman's age and menopausal status, and they recorded the change in CA-125 over time, every 4 months, and then depending on whether it rose or it stayed the same, the woman was classified into low risk, moderate, or high risk. And then, based on this triage, a transvaginal ultrasound was done. What did they show? They did show in a delayed analysis that there was some mortality reduction in the MMS arm in the range of about 20%, and more of it coming in year 7. This was a 14-year-old study. So between year 7 and 14, they showed a much bigger reduction. But as such, the results were not clear enough to warrant a change in practice. And therefore, on this side of the Atlantic, as well as on the other side of the Atlantic, it still remains that ovarian cancer screening in average risk woman does not have enough evidence to be put in clinical practice, and it can potentially cause harm for unindicated surgeries from false positive findings. So is this the time to change our strategy? Should we move away from CA-125s and ultrasounds? And is there a reason to change strategy? And if you ask me, I would click the green button. What is the reason? The reason is that high-grade serous tumors, we all know that ovarian cancers, the chunk of the ovarian cancer histology is contributed by epithelial tumors. And in that, you've got the high-grade serous tumors on one side. You've got a whole bunch of low-grade tumors and mucinous tumors that are slower growing. Now, high-grade serous tumors contribute about 75% of ovarian cancers, but they contribute almost 90% of deaths due to ovarian cancers. Where do these tumors arise from? Traditionally, they were thought to arise from the surface of the ovarian, the surface of the ovary or the ovarian epithelium itself, or from inclusion cysts that contained these epithelial cells. But now we've got a new hypothesis which has been tested and proven that there is potentially cells arising at the distal part of the fimbrial part of the fallopian tube called the stick lesions or the serous tubal intraepithelial carcinomas. How were these identified? These were identified when women with BRCA1 and 2 mutations, which fall under the hereditary breast ovarian cancer syndrome, underwent DSO for prophylaxis, case in point Angelina Jolie, and these tubes were examined histopathologically. They found that these women had changes in the distal part of their lesions which closely resembled high-grade serous tumors. They not only resembled cytologically, but they also resembled in the signature pattern that they had the P53 mutations, which is a hallmark of the high-grade serous tumors. And then the thought process changed towards, these are not potentially arising from the surface of the ovary. They're actually arising from the tube. And these cells shed from the distal end of the tube onto the surface of the ovary where the cells latch on and start growing. But at the same time that they are latching onto the ovary, they're already in the peritoneal cavity and they're taken by the peritoneal fluid to the subdiaphragmatic spaces and the paracolic spaces. And while it's on the ovary, it might potentially already be a peritoneal disease. And that's why most women are diagnosed in stage 3 and stage 4. Similarly, for endometrial cancer, although this is a reasonably good cancer to have with overall survival rates of 85%, even in this, most of the deaths that actually occur because of uterine cancers come from the type 2 or the non-endometrioid types, out of which the uterine serous carcinomas are the most notorious one. They arise on a background of atrophic endometrium, and they can present with extrauterine disease much actually show up as symptoms, and with very small primary tumors, they're already out there in the omentum and in the peritoneal cavity. So based on this, are we barking up the wrong tree? Are we looking at the right tests to actually be utilized? I believe so, which is where the crux of my talk comes from, which is the PAP-seq. And this is with acknowledgement to Lucy Gilbert from Professor Lucy Gilbert from McGill University, a path-breaking paper that looked at moving from testing for cytological abnormalities to genetic mutations. And the tests that they actually looked at was a pap smear test based on the success story of cervical screening and the fact that cancer cells exfoliate. They wanted to look at even our simple pap smears to see if these already show changes of what's happening up north in the uterine cavity as well as in the tubes and in the ovaries. We already know that endometrial cancer patients have pap smear abnormalities in almost half the cases. And that's why when a person has got a pap smear report of atypical glandular cells of unknown significance, it's mandatory to sample the endocervical canal as well as the endometrial canal. Based on this, what they actually did was come up with PAP-seq. They no longer made use of pap smear to look at just cytological abnormalities, which is what we do for cervical cancer, but they wanted to look at the mutations and aneuploidies that are commonly associated with uterine cancers and ovarian cancers in these cells that are shed from the cervix. So what they did is they went back and sampled about 1,000 women. Some of them had endometrial cancer diagnosed, some had ovarian cancer diagnosed, and with about 700 controls, they took their pap smears and they tested for 18 genes which are commonly implicated in hereditary and sporadic ovarian and endometrial cancers on the next generation sequencing platform. The common genetic mutations that were detected was P10 in endometrium and, as I mentioned, P53 for high-grade serous. So instead of just taking the pap smears alone from the surface of the cervix, from the ecto and endocervix, they also applied a brush to the inside of the uterine cavity, much like a Pipple sampler, and this brush was called the Tau brush. It's very similar to the endocervical brush. They sample cells from the inside of the uterus as well. So they now had two different sets of samples, the pap smears, which is routinely done, as well as an intrauterine pap smear. And what did they see? They saw that on the left, they saw that in the pap brush samples, in healthy controls, none showed mutations, or very few numbers. I think 3 out of 700 women showed some mutations. And in endometrial cancers, about 80% of women tested positive for at least one causative mutation on their pap brush samples. And in the ovarian cancer patients, about 35% to 40% tested positive for aneuploidies or a causative mutation. This rose by about 10 to 15% when the sample was directly taken from the uterine cavity. So it rose up to almost 95% in women who had an endometrial cancer. And this equals or is far better off than the Pipple sampler that we use for making a diagnosis in a woman with abnormal menstrual bleeding or postmenopausal bleeding with a high suspicion of endometrial cancer. And it could just be the next technology that we use for endometrial sampling. And in ovarian cancer, it rose by about 5-10%, and the put together aneuploidies and mutations came to about 45% in women who had ovarian cancer. And again, healthy controls didn't show any mutations. And this is very important because it points to the fact that these tests are specific. They don't just pick up any random mutation that could be present on our cells, and they test positive only when there is an underlying malignancy, which increases their specificity quite a bit. Now, because of this 40-45% that we got from the endometrial samples in the ovarian cancer space, they also wanted to test for circulating tumor DNA by collecting a peripheral blood sample from people who were from the women who were diagnosed with ovarian cancer. And when that was added on, it improved the detection rate in the ovarian cancer patients much by another 10 to 15%. So in the crux of PAP-seq is to look at genetic mutations that can be seen on cells that are exfoliated either from the cervix or even better from the uterine cavity by directly sampling the uterine cavity, and thereby increasing your chances of detecting a uterine cancer or an ovarian cancer. In ovarian cancer, your pickup rate will increase when you add on a component of peripheral blood sampling for circulating DNA cells as well. So these are exciting takeaways from the study. In ovarian cancer, what they realized is an equal number of the early stage ovarian cancers were also picked up as much as the late stage patients were picked up. And this is potentially because when it's early, the tumor is growing within the fallopian tube, and the tube is patent enough to allow cells to exfoliate through its cornual end and into the uterine cavity to be picked up by your sampler. Whereas as it progresses and grows, it becomes a matted mass, thereby not exfoliating cells out into the uterus, but rather exfoliating into the peritoneal cavity. And therefore, roughly about half the women who are picked up were early stage ovarian cancers, which raises the chances of us picking these cancers early and potentially having the only chance at curing ovarian cancer. Because as we know, if they get diagnosed in stage 3 and 4, they're going to have the 5-year survival rate is in the range of about 35 to 40%. The authors are also raising the possibility of this test being combined with other pre-existing tests like the transvaginal ultrasound and CA-125. The same applies for uterine cancer. High-grade cancers were picked up, and this is also very exciting because these cancers arise in much older women who are postmenopausal several years, arise on an atrophic background, and therefore our ultrasound cutoff of 4 mm and 5 mm may not be applicable in these patients, and therefore an ultrasound may have very limited application and may not pick up these tumors early. And projected costs may appear that these tests may cost as much as a mammogram or a colonoscopy or a CT scan that's already being used in the space of breast cancer screening as well as colon cancer screening as part of the Lynch syndrome screening. So acknowledgements to the team at McGill, which is which has got a whole bunch of funding to answer the next set of questions, which is the study that they published was retrospective. They already had diagnosed endometrial and ovarian cancer patients, and therefore they knew that the pickup rates would be higher than expected. Now, the next question was to extrapolate this into the general population and women of average and low risk. And Dr. Lucy Gilbert's team is on it, and this could potentially be the game changer that we're expecting it to be. And why is it? Is it the way forward? I believe it is, because genetic testing has made an entry into clinical practice. We already do it for aneuploidies in fetal maternal medicine, and in the oncology space, we are now HPV DNA testing is the standard of care for screening alongside pap smears. BRCA testing is being done for breast and ovarian cancers, and therapeutic implications in the form of PARP inhibitors for BRCA carriers is now standard routine practice. Endometrial cancer is moving away from pathological classification towards molecular classification, which is again based on genetic testing. And therefore, I believe that PAP-seq may be the game changer we're looking for in diagnosis of endometrial and ovarian cancers, and the point being at a much earlier stage so as to potentially cure these patients. Thank you so much for the patient hearing. I once again thank everybody for listening to me and for the organizers for giving me this opportunity.
Thank you, Dr. Anu. It's a very interesting talk. Dr. Rakhi, Dr. Anshu, do we have time for some questions?
Ma'am, sir, all the questions would be answered in that question and answer box.
It will be question and answer box. Okay, I think we heard three very interesting talks, but the problem is that we are in a country where sometimes with high levels of health disparities. So for majority of the country, we can't even take a pap smear, do not have the resources, especially human, to do a pap smear. And you have your metro cities and the 5-star hospitals which can give you everything that you can dream for. And that is why, if you look back, VIA and your HPV vaccine seems your best way forward for a mass prevention strategy. So I think while this will be academically interesting, I really have doubts how long it will be before we can get this in the market and how much it will be applicable to a population-based strategy in a country like India. The other thing I needed to ask Uma is that, Uma, in our country, tremendous shortage of perinatal pathologists. And I know you mentioned that we can do an X-ray test, but given the fact that many places have an access to an MRI, would you suggest an MRI as well if a perinatal pathologist is not available?
Yeah, I think, Bhaskar, that is a very valid point. We can get, if we can get an MRI and do some directed biopsy, a routine histopathologist will be able to interpret those slides. But again, I think the drive for that has to come from us as obstetricians to build this possibility within our departments, because all large hospitals, as you say, will have imaging facility. But we have to, I guess, talk to the pathology department and get them to be willing to look at these tissues and take the slides, because MRI alone may not give us as much information as the histopathology will. And my understanding is that perinatal pathology really is not dealt with much amongst, even when they do a pathology MD. So I think it's something that has to be included into the curriculum I guess the demand has to come from us.
Yeah, a quick question to Dr. Anbu. You raised a very important point that we always tell that endometrial cancer is very easy to treat, will present early. You raised a point that the type 2 endometrial metastases before they give rise to symptoms. Do you think endometrial people biopsy is something which is underutilized until such time that we have access to some better tests? We'll have a low threshold, especially in women above 35 presenting with AUB. We should have a low threshold for doing an outpatient endometrial people biopsy. A very simple procedure, can be easily done, very cheap.
So I think endometrial biopsy needs to be done as the most common choice, because it avoids an inpatient admission, it avoids anesthesia, and I think the traditional dilatation and curettage does not offer any advantage over an endometrial pupil biopsy. If there's any doubt about a localized growth, you can choose a hysteroscopy biopsy over a pipette. But definitely an outpatient endometrial biopsy should be the first choice of testing for women with AUB. And we've got clear guidelines for younger women as well, that anybody who fits into a high-risk profile, like has a background of infertility, polycystic ovarian syndrome, is obese, has got a family history, and if, although we do not have a clear-cut endometrial thickness cutoff, you need to have a high degree of clinical suspicion and subject them to an outpatient biopsy. I think DNC should be, rested. I think it's expensive. It's still blind. It subjects the women to anesthesia, and therefore it misses as many lesions as an endometrial pipette biopsy is done. I still think endometrial biopsy, outpatient biopsy, is terribly underutilized, and it should be the first choice that is offered per patient.
Yeah, especially because ultrasound is so subjective and many places do not have, the reliability of the person interpreting the scan is a question. Before Raki starts sending me messages to end, I think I'll thank all the three speakers. And thank you, Dr. Sujata, Raki, and Anshu for inviting us. So we had a very, very interesting session. Thank you.
I would like to
thank you very much also.
Yes,
thank you for the
Noida
opportunity.
Society, Raki, Dr. Sujata, Dr. Anshu, and the whole team for an excellent program and involving us as chairpersons. Thank you so much.
Thank you.
Thank you.
Thank you, sir, and thank you all our chairperson for the excellent participation and for their gracious presence. So now I would like to call Dr. Raki to please start the next session, session 2, that is oration. Hand it over to Dr. Raki. Dr. Raki, please.
Thank you, Anshu. We've got the dynamic President Dr. Alpesh Gandhi with us, who's there to grace the occasion of Noida OB-GYN Society annual CME. And he's been setting the trends of webinar, and he's doing it beautifully with both the hands full. He's the president of FOGSI 2020, and he has been the vice president in 2013, governing council member of ICOG FOGSI from 2016 to 17. He's a chairperson of Practical Obstetric Committee of FOGSI in 2009 to 2011. We have seen Dr. Alpesh Gandhi. I don't want to read the CV. We've seen Dr. Alpesh Gandhi, sir, doing great works through the webinar platform, and he's adapted that very beautifully. And we've got a successful, so many CSR activities under his banner. Welcome, Dr. Alpesh Gandhi, sir. I would like to welcome our next president, chairperson. Can we have the next slide, please? We've got another star with us, that is Dr. Nandita Palshetkar, who has just handed over her presidency to Dr. Alpesh Gandhi to do the honors. And Dr. Nandita Palshetkar, whom we know, all of us, she's done huge amount of work during her tenure. She is the director at 9 Bloom IVF centers, and she's a professor in OP-GYN in D.Y. Patil Medical College at Navi Mumbai. She's teacher for super specialty degree and FND reproductive medicine. She's practicing infertility for the past 25 years. She's the former president of FOGSI from 2019 to 2020, former president of NOGS at present, and present she is the president of NOGS, and she has written many chapters, more than 150, and received many awards and delivered orations, more than 61, and delivered more than 1,000 talks. We see her lively, imparting her knowledge all through and logging in a day, at least to 4 webinars in a day, very graciously. Dr. Nandita. Now I would like to hand over to Dr. Sujata to do the honors of calling the next chairperson. Next slide, please.
It's truly an honor to introduce stalwarts like Dr. Chandravati, a true academician. She is the Professor Emeritus of the Department of Obs and Gynae at KG Medical College, the Director of Krishna Medical Center, Lucknow, and a proprietor of Krishna Nursing and Paramedical Institute, Lucknow. She was the president of the UP chapter, president of Lucknow Obstetrics Society, and vice president of FOGSI in 2001-2002. Most interesting of all, running an NGO called the Women's Health Improvement and Education at Lucknow. And of course, several awards to her credit. The Mahadevi Verma Scholarship up to the intermediate, and most important at our time, the winner of the Best Teachers Award from KGS Medical College and the Lions International Best Fellow Guide of the College of Obstetrics and Gynecology by the Governing Council of Dr. C.S. Dawn, Indian College of Maternal and Child Health, Dr. C.S. Dawn Memorial. A great honor, ma'am, to have you as our chairperson today.
I would like Dr. Alpesh Gandhi sir to kindly give the presidential address and then the introduction of the oration. The speaker would be there. Can we have the slides off, please?
Respected Dr. Kamal Bakshi Madam, Dr. Chandravati Madam, my friend Dr. Nandita, Dr. Suvarna, Dr. Mala, Dr. Pratap Kumar, Dr. Bhaskar, Dr. Krishnendu, Dr. Sujata, Dr. Ansu, Dr. Rakhi, eminent faculties, dear friends. First of all, a very good afternoon to all of you. We are thankful to Dr. Sujata, President Noida Society, and Team Noida for giving us this opportunity to share this oration. I would also like to congratulate Noida Society for organizing this annual CME and continuing this great academic in this difficult time of COVID-19. You all are doing good work and continuing also essential and time-sensitive services for the women of India. It's an honor and privilege, also a pride, to chair an oration going to be delivered by none other than my mentor, a very good orator and most humble person, Dr. Professor Sabaratnam Arul Kumaran. It is always an opportunity to listen to you, sir. Sir, your topics for orations are always new, interesting, and very informative. Today also, you are going to speak on a topic, very interesting topic, individual and institutional professionalism. It is also a privilege to chair a session on the same podium with Chandravati Madam and Nandita Palsetkar. With this, for introduction of Professor Dr. Sabaratnam Arul Kumaran, I hand over mic to Dr. Nandita and Dr. Chandravati Madam. Thank you.
Thank you, sir. Can we have the PPT slide, please?
Madam, would you do the honors?
Nandita karo.
Actually, thank you, Dr. Chandravati ma'am. I just want to say hello to everybody.
Can we have Dr. Arul Kumar's CV, please? I'm sorry, Dr. Nandita.
Yeah, no, I just want to say hello to everybody and thank you. I don't want to take everybody's names. Alpesh has mentioned everybody, but I want to say thank you to Noida Society. You know, I did my North Zone FOGSI last year, and since then they've really become very close to my heart. And I want to thank Sujata, Rakhi, and Anshu has been the young kid on the block. I think fantastic. I heard the last lectures, which were very good, amazing talks and really good topics. So now let me come to Sir, Dr. Professor Arul Kumaran. As Alpesh said, he's a mentor. Let me tell you one incident that shows his personality. You know, one young gynecologist was giving a talk, and she was speaking on an international forum, and she was very scared, in the sense the accent was different, couldn't understand everything like that. And Professor Arul Kumaran was there, and he said, don't worry. Everybody's accent is different, but what you're talking, it's your knowledge, and they will understand the translation. So you don't have to worry. You know, this little bit of information which he assured this young gynecologist on an international forum, I think that's fantastic. That's how he mentors everybody. And I'm really happy today to be on the same forum and being a chairperson to introduce him. So Professor Arul Kumaran is the Professor Emeritus, 1 minute, I'll just reduce this, is the Professor Emeritus of OBGY, St. George's University of London. After he retired from his position as a professor and head of OBGYN from 2001 to 2013. He is the founder president of the OBGY St. George Medical School, University of Nicosia. He is a visiting professor of the Institute of Global Health Policy Innovation, Imperial College London. He was also the past president of FIGO, where he brought in a lot of new things, and also the past president of the British Medical Association, and of course the past president of the Royal College of OBGYN of UK. He was appointed the Knight Bachelor by Her Majesty the Queen of the UK in her birthday honours list in June 2009 in recognition of his services to medicine and healthcare. And the amount of work that he has put in, especially in the famous abortion law of Ireland, where they brought about a change. I think Professor Arul Kumaran is responsible for that, and I'm really happy to present to you Professor Arul Kumaran, who's going to give us a real insight into professionalism. Sir, the stage is all yours. Thank you.
Good morning, and thank you very much, Nandita, for the excellent introduction. Very, very kind of you, and also Alpesh. So I would like to thank the chairpersons and how as individuals we should be responsible for the ethics and responsibility of organizations. So when we talk about professionalism, there's a word behind it called profession. So profession can be accountancy, engineering, medicine, architecture, anything. So it's commonly associated with a profession, and each of the professionals will show some true professionalism in their discipline. So as a doctor, as a professional, we must know what is the minimum expectation by patients as well as the public on our behavior and how we deliver healthcare. And how does these characteristics together form the foundation of doctor-patient relationship, which is trust and respect. So when they come, they trust and they respect you, and how do we reciprocate to this? So I'm going to talk a little bit about profession and professionalism, and then take a few case examples. At the outset, I declare no conflict of interest, and like to thank Professor Frank Chevenak, my friend, for providing some useful hints, an article from BMJ, where I took some of the literature. So who is a professional? Professional is a person who have a particular set of skills in their chosen field at a level to be considered as an expert. So if we take a trainee obstetrician, he or she is not a professional, but they have to go through the mill and become more experienced. And once they become an expert, we call a professional. The skill is acquired through learning, knowledge, training, and practice of the relevant skills. So they have to do the relevant skills. They have to keep on practicing to be considered as a professional. And not only that, they had to demonstrate they have acquired their learning by certain qualifications and accreditations. So qualifications like the DGO, MD, FRCOG, and so on, and accredited by organizations like the Indian College of ONG or the Royal College. And the validity of this expertise should be maintained by ongoing learning, CPD and appraisal and revalidation. So not only we have to learn, so this is a nice, fantastic 3 lectures we heard just now, and that is helping us to improve our professional development. But also we have to be appraised by a senior colleague so that they believe that we have reached a standard, and they have to certify that we can be revalidated for the next 5 years to continue our practice, or next 3 years to continue our practice. Our revalidation is something which was started about 8 to 10 years ago in the UK, but in some countries it is not available still. Now, the professional must maintain standards and respectability. Standards means they are expected to have the ability and dedication to achieve the set standards in their duties that peers finds acceptable. So if you're taking a gynecologist, if they're doing a certain number of operations per year, they should have less complications. And also expectations of the professional will be to work in a manner appropriate to the nature of their profession. So they can't be just doing 2 operations for the year and say they are the experts, but it is 50 or 100 as people can recognize they are experts in this field, they're doing enough and they are not having much complications. In medicine, it's not only about the practice, but also good standards of personal appearance appropriate for the job, and also standards of speech and personal conduct, not only in the workplace, but also outside. We must behave in such a way that we earn the respect. And attributes should confirm to a patient an acceptable standard of respectability. So the patient, if the patient sees us in the shopping market or someplace, they should really pay respect, saying that you are behaving you are dressed in an appropriate manner and you are behaving appropriately. So doing what is right when expected by law and ethics is quite an important thing. And that is what we call as a moral compass. So we have to behave, and it's really a personal pride to be a professional. So if I go and say, I'm a member of the Indian College of ONG, I should be very proud about it because the college has recognized me, and I should also behave in such a way that I shouldn't bring any disregard or disgrace to the college. So we must have a certain responsibility and reliability and probity. So we must honor commitments. So if you're saying we are running a clinic at a certain time or a theater, we must honor that commitment. We can't wait, let a lot of people wait, the anesthetists and the staff wait. So it's quite important to honor the commitments and keep promises. If you say a patient that I'm going to get back to you with more information, you must do that. So that is actually a key responsibility, that the patient or the staff thinks you're a reliable individual. And you must ensure tasks and duties are complete and addressed by your initiative, leading by example. So if you don't do that, then the junior staff is not going to do the same. So I think it is quite important we have to lead by example, how we treat patients, how we do the ward rounds, do the theater in time, and so forth. Lack of immediate attention to one duties can be different between life and death. So if you're a night on call and they say there's a bleeding woman and come immediately, if you delay, then that can be a cause of life and death. So you have to be committed for the job and not take it lightly. Probity is quite a good thing. It is honest, upright, fair, law-abiding. Yesterday, we had a seminar by FIGO at the Royal College, and I was participating. And in Egypt, 70–80% of female circumcisions are done by doctors. So this is not gynecologists, but general practitioners. And the question about probity comes in. It's not only they're doing because they think there's a culture, but also because they have financial gains. So there are lots of issues about our clinical practice. In some countries, it's different. But we in ourselves have to think what is best in our society. And the central trust is placed in a medical profession, and we should uphold the reputations by our own actions. And our conduct, as we said, should earn respect, and we should also in return respect the authority of the rules, maintain when managing. Say if you're a practitioner running a hospital or a nursing home and you employ the others, you must also give them fair deals so that they don't get shorthanded and others will respect you. And you have to be courteous and should respect the rights, dignity, and autonomy of the others who are working with you. So the professional behavior is something you take pride in doing your job well and pay attention to detail and take personal responsibility for your actions. And all the time seek to improve your skills. So this CMCPD seminar, the last 3 lectures are key examples. And also you might have to go to another hospital to learn new skills and not to be satisfied with substandard results. You have to do the best as much as you can. So for example, the UMass talk, it says unexplained stillbirth. If you don't really seek to learn, then you won't do better. So I think it's quite important. The substandard results should be improved. And acknowledge mistakes and learn from them. So if you make a mistake, don't hide it. Hiding is a crime. So I think we have to say, I made a mistake in doing this. I'm sorry about it. And next time you do better. And show respect for those who consult somebody in a professional capacity. This is quite a key issue, and Nandita raised the issue about a young presenter. But in our own profession, there are junior doctors or junior colleagues who are appointed as consultants who come and ask you for help with surgery, other things. And you shouldn't really badmouth them, but you should try and support them as much as possible and help them so that you earn respect rather than trying to gain respect by downplaying the others. Now, if the opposite is unprofessional behavior, criminal behavior or conviction, so that's bad. So for a society, if you are committed a crime as a doctor, then that is really bad. So I think that should be avoided. Disregard for well-being of patients, failing to honor clinical commitments as not turning up for the theater or in time or the clinics in time, rude abuse or disrespectful behavior. This is not that uncommon even in the UK and in other countries. So we had to respect each other, the patients who come to us. And we had to be responsible. Irresponsible, apathetic attitude. We just, for example, if you order a blood report, you should be able to review that before you see the patient again. And showing disregard for time and effort of those who are relying on them. For example, consistently bad timekeeping, which I mentioned over and over again. And anything that undermines public confidence is bad behavior. And anything undermines the reputation of the standing. Selfishness, accepting unsatisfactory clinical standards. So if you have surgery done and repeatedly, if you're getting complications, you have to find out why and you have to sort it out. And gratuitous criticisms of colleagues and others. So if somebody is doing badly, one of your colleagues, then it's your duty to go and talk to them and see how they can improve their standards rather than criticizing them in public. Inappropriate relationship with patients, having, for example, trying to make use of the patient's position to gain advantage like a loan, or even having, in the UK, there have been cases of sexual relationship and so forth. So that is not, which is very respectful of a profession. And treating patient when not fit to do so. If the patient is clinically very ill, like a terminal cancer, there's no point trying to do a surgery in order to get the money. You have to tell them the real prognosis and give them what is possible and what is not possible. So there are a lot of lists you can carry on in unprofessional behavior, dishonest business or financial dealings, abuse of the doctor-patient relationship, which I mentioned. And in the UK, it's not that uncommon for doctors to find drinking and driving over the limit. And when they get caught, they are warned not to do that because they might also have to see a patient. So that is quite important thing. So there's a social responsibility we have. Professional role is individual's ability to carry out, and caring nature of the health profession should be maintained. The basic line is to desire to do good. Now we go to professional integrity, which means the compassion for those suffering in pain and hardship should be shown. And also you have to build up the team to show empathy and whatever can be done. And a proper and responsible role in society. So if something is done unjustifiably, if you can't correct it, then as an organization, collectively, like the FOGSI or the Indian College, you have to see how we can change the situation in the society to better treatment. And good employment practices, I mentioned this before, and to be aware of social issues of the medical profession. The professional integrity, I don't have to do much on that. As I mentioned earlier, substance abuse, driving while unfit to do so, that is not very good. You have to do in an emergency situation, a good Samaritan act. So if you're a doctor and somebody is collapsed, you must make sure that you go and see. And doing what is right is according to the law is what is important. And persisting in what you are doing right. So these are general characteristics, and this has evolved over the years. So here are a number of people. Hippocrates started the Hippocratic Oath in a small island called Kos in Greece. He changed the barber surgeon to become a profession. But way along the line, these 7 figures, Plato, John Gregory, Aristotle, and so forth, have changed the way medicine should think. So I'm going to talk one sentence about each of them. Aristotle mentioned, in general, the ethical principle of justice requires that everyone receive his or her due. So unlike the financial situation of the patient, if the patient is poor or rich, we have to treat them according to what they really deserve. Plato said someone who commits himself to life of service to fellow citizens. So that means if you are saying you're a doctor, whether it's night, day, or weekend, you should be available unless you can make some alternate arrangement. That you must have a leadership quality to do that. And Peter Drucker said, leadership without direction is useless. As the pace of change in our world continues to accelerate, strong basic values become increasingly necessary, good leadership. So you have to be a doctor as a good leader as well to make sure that your commitment is carried out. John Gregory was a physician and philosopher, said, commit himself or herself to the scientific and clinical community, makes the protection and promotion of patients' interests the primary concern. So even if you had to go for a party at a particular time or do something, the main goal should be the patient. After that, only your interest comes in. So the mix, the protection interest is systematically a major consideration, which is called ethical practice. Now, Thomas Percival introduced what is called organizational professionalism. So you might be a gynecologist, but you must belong to an organization like the FOGSI or the Indian College, or here in the UK, the Royal College, and you must do what is best as an organization as well. It's not good enough you behaving, but the organization must put in various rules and regulations so that we perform better and develop respect and trust with the organization. So he defines organizational professionalism in response to disputes about medical, surgical staff that might threaten paralyze organization as well. So that is another responsibility. And defines organizational professionalism in response to rationing of hospital resources, especially in the formulary. So if there is a problem with medication, we can't just walk away saying there is no medication. We have to talk to the administrators and see what can be done. And this was amply demonstrated, the lack of the personal protective equipment in the UK with the COVID pandemic. Now, Machiavellian is really a different types of ethic, which is sneaky, cunning, and lacking a moral compass in some ways. So he generally tries to get something with a political justification or professional justification. If it doesn't work, then he tries to behave in such a way to attract attention of the politicians and to get whatever he wants done. This is not very uncommon. We go and ask politicians to change the law, and if they don't change the law, then you go to the press, to the newspapers and the TV and publicize what is wrong with the politicians, then they will start action. That is called Machiavellian ethics, which is not a nice thing to do, but sometimes it is needed to achieve what you like to do. Now, I'm talking a lot about professionalism. So how do we really know the professional is acting according to what we are talking up to now? So the General Medical Council and the Nursing and Midwifery Council has come up with a few things, and they check this every 2 years, and the second year and the fourth year in a 5-year cycle by multi-source feedback, what we call a 360-degree appraisal, because they ask around a lot of people to say few things. And the things they look for is whether you are making patient your first concern, whether you're treating patients politely, and are you respecting patients, are you listening to patients, are you giving information to patients, and so forth. And that is the general concern. Then whether you're honest and trustworthy, Are you protecting confidential information? Are you avoiding abuse of your position and working well with the colleagues and so on? And this is necessary for a 5-year revalidation. So the multi-source feedback is done by giving standard forms to medical colleagues, about 10 to 12, non-medical colleagues, they would like nurses and attendants and so on, and patients, and they collect 26 to 30 forms in the 2nd and 4th year, and they go through that. Let me give you an example. Now at St. George's, when I'm head of department, every 3 years we have a validation process. So the question here is actually managers' personal effectiveness. The blue is the mark given by the other people. So I'm saying stroke personal vision. I'm saying 4.5. Delegates appropriately. I think I'm delegating less. Others are saying I'm giving too much work. Effectively uses time and energy. So you can compare what the others say and what you think. That gives a position for you to improve your standards. And all these qualities can be put on a spider chart, as you could see here. And what is in blue is what the others think about you, and what is in red is what you think about it. So if there is a wide margin, then they can arrange for counseling as to how you can improve yourself. So this is for a managerial circuit, like managing and performing others, managing team, managers, conflict, and so forth. But you can convert that into a clinical circle in decision-making, relationship with colleagues, adheres to safe practice, personal development portfolio, whether you have CPD, CME certificates, and so on, whether there are any complaints from patients, and whether you are a teacher, and so on. And this is what is being done at the end of 2 year and 4th year, and then they are looked at. In addition, we asked to read some journals like the Obstetrician and Gynecologist, and we had to answer MCQs, single best answer questions. So the Royal College helps. On the left-hand side of you can see it helps with the literature and the MCQs, whereas the National Health Service Hospital does the multi-source feedback, and these two are joined and sent to the General Medical Council for revalidation. So in some way, the clinical practice, science drives the clinical work, all the meta-analysis and so on. Ethics drives practice, but science is driven by data and ethics is driven by argument, and these both are taken. And it is not perfect in medicine. The art of medicine lies in balance in the probabilities by taking the science and what can be done. So what I'm going to do now for the next 5 minutes is to talk you through what is the difference between individual and collective professionalism. And we had to demonstrate through the colleges what we can do. So I'm going to take 3 examples: Northwick Park Hospital, Galway Hospital, and St. George's Hospital. Nandita mentioned about the Galway Hospital incident. This is Northwick Hospital, which is north of London. There were 10 maternal deaths in 3 years. That is, they deliver 5,000 cases a year, so 15,000 cases, there are 10 maternal deaths. Normally, in the UK, it should be 10 per 100,000. So the total number of deaths were far in excess. And these are 2 young ladies who died after childbirth. One was a Filipino nurse, one was from Sri Lanka, and they had bled to death. And I have been asked to go and see, and so I had to suspend 2 consultants, 2 asked to leave, 1 removed from labor ward duties. And I said what the problems were, and we had to remove them because they don't have the capacity to work there. Now this is very difficult because it is one of your colleagues, you are trying to take action, but you have to do that for the well-being of the organization. This is like the Bhagavad Gita, where Lord Krishna is telling Arjuna, you're not fighting your half brothers, but you're fighting what is bad. So for 18 months, I was managing, and we didn't have a single maternal death, and I brought in some changes called maternity dashboard and consultant on call. And we turned it around, and this is just a quick example of 6 maternal deaths out of 10. The consultant did not even know that the patient was sick. So there was a problem way down the bottom as well. Now, this is nothing unusual because the confidential inquiry says 60 to 70% of mothers die because of suboptimal care. So I brought in 2 things through the college. So this is where the individual's experience become the organization's ethical responsibility. And we introduced what is called as maternity dashboard. It's like driving a car. When the petrol is not showing into the orange or red, you keep on driving. When it gets the red, you start sweating and you want to go to the petrol station. So it's a similar thing. You plot the number of deliveries or book PPH, admission to ICU on a monthly basis. And if it is beyond a certain level, then it shows red, and then you'll take action rather than waiting too long for bad things to happen. The second thing I brought was responsibility of consultant on call. So that is, if there are major problems, they have to be there next to the patient. In the UK, the practice is different because the consultants stay at home over the weekend and in the nights. Now it is increasingly they have to stay in the hospital. Unlike in India, if you're running your own nursing home, you'll be there all the time. So it's slightly different. So these are examples where I said the responsibility of the consultant call. It was not a very popular move, but we had to bring it in. And then we had to see that during the early hours of the morning, the maternal and fetal complications were more because the surveillance of what is happening is like a surveillance plane here. In the weekends and the nights, there are not senior people present. So if you get into a plane and say the announcement comes, the captain says, the first officer is flying, I'm at home, good luck, then you will get down from the plane. So that was the situation. So here I have applied what we call as a Machiavellian ethics. So I asked the government to give funding to put consultants 24/7, and they were refusing. So I went to the newspapers and complained, which came as an article. And after that, the government started negotiating to give more consultants to the hospitals. And next example is Savita Halapanava, who is a dentist from India who was in Galway, who had 19 weeks. She ruptured the membranes and she died of sepsis 5-6 days later. And there was a huge outcry, and I was asked to be the adjudicator or chairman of the committee. And there I mentioned there are a number of things which went wrong. Inadequate care by nursing staff, medical staff, but also the law was the problem because Ireland, they don't allow termination of pregnancy. And I had to go to the parliament and give evidence, get the Irish ONG Society to be mobilized, work with the Irish Family Planning Association, and mobilized a group of people. And through the joint OIRIACs, which is the MPs, we forced a referendum. And as Nandita mentioned, by 66%, the referendum was won. And they said the island has turned into journey to care, compassion, and choice. So finally, before I conclude, I would like to finish with this 7 C's, I call it. You should impart on all the junior doctors and ourselves who have to abide by that. One is commitment to the profession for patient care. So if I'm called in the night, I must get up and go. Second is I should be compassionate, caring, empathy. Third is courteous. So you behave in a respectful way, show them respect and dignity. Don't ignore the partner or the parents or somebody. Competent. So you must have the knowledge, skills, and decision-making capacity. You must be a good communicator. You have to listen carefully, explain to the patient and the relatives what is going on and what is going to be done. And you have to impart confidence in your team so that they know that the good thing is going to happen. And you have to coordinate all the work by team leader. You don't just say, do this and carry away. You have to be a good team leader, researcher, and administrator. So I'm going to take a case example and see how I test myself. 2 o'clock in the morning, I got a call from a midwife who said, come to the theater, patient has cardiac arrest. So I reached the hospital within 7 minutes, ignoring all the traffic lights. So I was not only committed, I went to the theater, and outside was the husband. I spoke to him, courteous, compassion, communication. I had to do an immediate laparotomy. First patient had a amniotic fluid embolism, so she had massive blood loss, but we had to treat. So we had cardiac massage, we did a hysterectomy. So that is actually showing confidence and competency. Controlled the hemorrhage, sent her to the ITU, and came back to the labor ward to debrief the family as well as the team. But unfortunately, the patient collapsed and died in the ITU. But I attended the postmortem, and it was demonstrated as a massive embolus, which was physically choking the pulmonary vessels. And then a few days later, I had to really go and speak to the family. And as I walked into the room with the sister in charge, the husband got up, came straight to me and hugged me and started crying. So it was very emotional for me. I too cried, but I explained the postmortem findings and made the arrangements for them to take the body and how to conduct the funeral and so on. So these are ways by which we can check ourselves whenever there is an acute emergency and things go wrong, whether we are given the 7 C's for that occasion. So that is individual professionalism, whether we are exhibited or not. So this is my last slide. We always talk about women and children first. So I was curious to find out where the word came from. It is from a ship called HMS Birkenhead, which sailed off South Africa. And there were not enough lifeboats. And the captain orders the crew to play the band and orders the women and children to the lifeboat first. And only 193 out of 643 survived. So this is what is called act of professionalism and chivalry. And that I get recollected with the COVID incident in the UK. There are a lot of doctors, nurses, midwives who are going for work, and they have lost their lives. That is professionalism and chivalry. So with that, I will thank you for giving me this opportunity, and thank you very much. Thank you.
I think, thank you, Dr. Arul Kumaran. I think it is a pleasure to see you today after we had our AICUG in January 2020 at Lucknow. And I still remember your talks there, your presence all 5 days of the conference. It is always a pleasure to listen to you, and then you start thinking. When you talk today about the professionalism and other things, you know, one starts thinking, are we having all those qualities? Are we missing something? Should we improve? At this age also, I start feeling there's something I may not be doing right. I need to improve. So there's always, every day you learn something. You always learn by your, sometimes you might not recognize that an error, but there might be an error and you want to learn from that and you want to improve it. And I would always tell my younger juniors and colleagues to always learn one point, that you have to be very, very cordial, sympathetic, understanding to your colleagues, to your juniors, to your friends, to your patients, their relations through the community and the society. And I think that is the professionalism what we have been all. We might be whatever skill we have, but those skills are useless if you're not a good human being and not understanding human being. Thank you very much for your wonderful talk today. I thoroughly enjoyed it. I will leave it to Alpesh and Nandita to comment on it. Thank you.
Thank you. Thank you very much for your very kind comments.
I think Dr. Chandravati has done it so beautifully. Sir, I think for the youngsters, it is an amazing talk, because I think there is a generation gap between even your generation and us and the youngsters also. And the values with which you're brought up with, I think if you bring them to your profession, that would be something. So I think this is what we need to know, that the values which we learn from our families and we carry them, how we respect our father. What I feel for me is that you should think or your patient as your family. And I think you put it in so beautifully in words. I mean, that was, you know, it is really amazing. Thank you very much, sir. I think it was a wonderful, wonderful lecture.
Thank you. Thank you very much. Thank you.
Thank you so much. I don't know if, I think Alpesh had another CME. So he was...
Okay, sure. And thanks to everybody.
Just want to say thank you on behalf of Noida OBGY Society, and of course all of us FOGSians, that you're always there for us.
Virtually Professor Kamal Bakshi and Pratap Kumar and so on. So it's nice to see all of you again.
Dr. Kamal Bakshi is very active. She's always there on every program.
Yeah. Thank you
And
very
for
much to everybody. Thank you.
Dr.
And
Madhu is
Dr.
also
Kamal Bakshi is always there for our Noida programs, definitely. She always makes it a point.
Raki, fantastic job. You all are doing a great job. Madhu, I mean Anshu and Sujata.
Thank you. I would like to thank all the chairpersons and my speaker, Dr. Arun Kumaran, the chairpersons, all the three who graced the occasion very beautifully, Dr. Alpesh Gandhi sir, Dr. Nandita ma'am, and Dr. Chandravati ma'am. For
Thank you, Raki. Thank you very much.
Thank you very much.
Thank you, everyone.
Thank
Thanks.
you.
I hand over the proceedings to Dr. Anshu and Dr. Sujata.
Thank you, ma'am, and thank you our all the seniors, chairpersons, and our all speakers, our speaker. So now I would like to start our third session of a keynote, and for this I want to call our chairperson. Our first chairperson is Dr. Kamal Bakshi, ma'am, and she is a former professor and head of the Department of Obstetrics and Gynecology, AIMS, New Delhi, and medical director, the Women Clinic, Noida. She is a senior consultant obstetrics and gynecology in Indraprastha Apollo Hospital, Fortis, Lafayette, and former president FOGSI and Indian Society of Perinatology and the Reproductive Biology. Ma'am has a awards, list of awards, and these are few: the Dr. B.C. Roy National Award and is eminent medical teacher, Lifetime Achievement Award of the FOGSI ISAR Logs, All India Institute of Medical Sciences, and the Indian Society of Assisted Reproductive Delhi Chapter, Women of the Year Award in 1998, Bharat Jyoti Award, Indo-Norwegian Scientist Award, a living legend title given by the Gynecological Surgery Society of India, and the Kamal Bakshi Oration in the Institute in the recognition of the pioneering work in a fetal medicine. Dr. APJ Kalam's Living Legend Award as a teacher, academician, pioneer, and orator for the Women Health Care awarded by the Delhi Gynecologist Forum, and the lots of publication in few the more than 250 national and the international journal. Ma'am, please grace the session. Now I would like to call our next chairperson, ma'am. Next slide, please. Dr. Kavita Bapat. Dr. Please chair the session, ma'am. And she's a director of One Center for Gynecologist Excellence, senior practicing obs-gynae at Indore, one-day hysteroscopy specialist, FOGSI affiliated colposcopy center, the vice president of FOGSI 2021, organizing secretary ICOG 2021 Indore, which is to be held, and the president Indore Menopause Society, vice president MPOG, and the President MP Chapter of Vaginal Surgeons, Secretary MP IGE, Executive Member ISAR, Executive Member of IGE, and the Chairperson Breast Committee FOGSI 2016-18. Ma'am is a past President of Obs Gynae Society of Indore and the Governing Council Member of ICOG, past President Lions Club Indore, and the awarded winner of the NICA Indore and the Caption of Industry. Ma'am, please grace the session. I think our next chairperson is, next slide please, is our own founder member of Noida Obs and Gynae Society, Dr. Madhu Srivastava. She is presently a director of Obstetrics and the Gynecology Cloud9 Hospital, Noida. Formerly, ma'am was a principal consultant and the head of the Department of Obstetrics and Gynecology, Fortis Hospital, Noida, and senior consultant obstetrics and gynecology at Apollo Hospital, Noida. She has expertise of a vast experience of the clinical practice of more than 40 years. She is a high-risk obstetrics, gynae endoscopy, advanced gynae surgery, infertility, adolescent clinic, and the menopausal clinic and the colposcopy. Ma'am has academic activities and the positions held as a former president of Noida Obs and Gynae Society, as a founder member of Noida Obs and Gynae Society, member of Royal College of Obstetrics and Gynecology. The madam has conducted conferences, conducted various CMEs and the workshops as a founder member of Noida Obs and Gynae Society and the senior advisor of the Noida Obs and Gynae Society, member of Association of Delhi Obs and Gynae Society. Ma'am, please chair the session. Now I would like our all chairperson to please start our third session, that is keynote. Please hand it over to our chairperson.
Dr. Kamal Bakshi ma'am, can You need to unmute yourself, ma'am. It's muted. Left side, lower down. The button is that. Dr. Jayanta, can you help Dr. Karmal Bakshi to unmute her? If you could do that on us.
Yeah, it's on.
Yeah. Ma'am, you can speak. It is unmuted, ma'am.
Is it unmuted?
Yes, ma'am. We can hear you.
Good evening, everybody. First of all, I would say I have known Professor Kumar Pratap for many years, and I would say what we heard today, just now, Professor Arul Kumaran, you'll find each and every quality in Professor Pratap Kumar. He's the role model as a good colleague, as a teacher, as a friend, and his department is one of the best departments. Now, coming to Dr. Madhu Srivastav, she's the one, gave birth to the Noida and Ops and Gynae Society with other 9 members. So I would say, I would request Dr. Madhu Srivastav to introduce Professor Pratap Kumar, Dr. Madhu Srivastav. Can we have? Is Dr. Madhu Srivastav there?
Please unmute. Can you unmute? Yes.
Okay.
Thank you, Madam Bakshi. And it's a great privilege and proud moment for all of us, especially Gynae Society, Noida Gynae Society, to welcome Professor Pratap Kumar. I know he's a great teacher. We all know that. And it's a real pleasure to welcome him. He's a professor of Gynae, head of the Division of Reproductive Medicine at Kasturba Medical College, Manipal. He's been a national vice president of FOGSI 1999. He was an inspector, examiner, and advisor of National Board of Examination, examiner of undergraduate and postgraduate in several universities. He was appointed on editorial committee of the several journals. He's been president Karnataka State OBGY Society from 2011 to 2012. He's been a member of Task Force of Human Developmental and Disease Biology, Department of Biotechnology, New Delhi. He's been a member of Project Review Group on Reproductive and Child Health, ICMR, New Delhi. And there's many awards and publications to him. He's been, it's basically on Fertivision 2018, Leading Lights in the Field of Reproductive Medicine in 2018 by IFS. Dr. Durusha Lifetime Achievement Award in 2017 by ISAR. He's been a FOGSI. Dr. Kuti's Lifetime Achievement Award for 2011 and 12. Dr. D.K. Tank Reproductive Healthcare Promotion Trophy. He has more than 300 publications and presented more than 800 presentations in national and international congress. He's been editor of 10 textbooks and contributed to several chapters. I really welcome him for his talk, which is so close and so practical in this era, in this millennium education world.
Thank you very much, Madam Srivastav, for introducing me. And it's definitely a pleasure to give a talk to the Noida Society, as well as all the members who are here listening to us. The aging ovary, dilemmas in young and old. Thank you, Dr. Sujata, for inviting me and giving me an opportunity to talk to your society. I must thank Anshu, Rakhi, and all of you for having given me this opportunity. And Madam Kamal Bakshi, I have a very special place in my heart for you, for having said good things. And Professor Arul Kumaran, great pleasure seeing you here. So I bring greetings from Manipal, University town of Karnataka State. Now we all know the mechanism of ovarian aging is not understood well in the clinical practice. We know that when the girl is born, she has so many oocytes even before birth itself. But
At the age of 7 years, it goes down. And definitely, when she becomes an adult, it is quite a few in number already. If you look at the chart, just by around 35 years of age itself, the oocytes go in number to a large proportion, disproportion I should say, and it just disappears after 40 years. So the ovarian reserve is very important to understand, because we know that this is a problem where we have to understand why is it so, why is it like that. Let us understand that point, and we know that many things go wrong as age advances, and we need to understand the process of the whole ovarian aging itself. Now, let us understand what happens to the ovarian aging here. The ovarian aging by puberty, a huge number of follicles go down in numbers subsequently, and just about 400 oocytes are in action. 99% of the follicles will undergo atresia. Now, looking at this diagram, by the age of 30, only 12% of the pre-birth primordial follicles population is present. Now, looking comparison to the other kind of species, the mice, the incidence of aneuploidy among fertilized eggs does not exceed more than 2%. But look at the human being. The humans have about 10 to 30% of fertilized human eggs have gone wrong in the chromosomes. I think we are completely different from mice, and we have a large number of chromosome abnormalities anyway. So when looking at the anti-Mullerian hormone, the only hormone which we can really say the reserve is good or bad, because it comes from pre-antral and small antral follicle, and we know that the normal levels are between 1.5 to 3.5 nanogram per ml. Now, the main physiological role of AMH is the inhibition of early stages of follicular development, the only marker of ovarian reserve, independent of menstrual cycle, and unaffected by the use of oral contraceptives or GnRH agonists. The circulating AMH level reflect output of all granulosa cells within the follicles, and we know the outcome. But the antral follicular count also we have been discussing over the years. I always say if there are 8 to 10 antral follicles in each ovary, it is quite good reserve. Now, looking at the aneuploidy, you'll realize 10% of the eggs are aneuploidic in young women, and 30% at the age of 40, and 50% at 43. And nearly all the eggs are bad by about 45 years. I don't think any kind of rejuvenation really helps at that age. But the fertility in human follows an inverse U curve. What is this inverse U curve? The first part of the slide on the left, you'll realize when they are very young, also the oocytes can be abnormal. When they are older, it can also be abnormal. That means a very young pregnant woman who's trying for pregnancy may also have some more of aneuploidy like the older women. And usually the right side picture tells you how the fertility in human follows the inverse definitely, but around 30 to 35 years you'll find is the best age to conceive. So beyond 35 years, we know that things go wrong once again. But interestingly, when they study these chromosomes, the cohesion weakening with age, deterioration of the molecular glue, the chromatids are basically together. The sister chromatids in human oocytes, they lose cohesion with age, which may lead to incorrect alignment of bivalent meiosis itself. So look at the young bivalent and the old aged one. There is a definite relation between the bivalent and the glue. The molecular glue is less at the older woman. So that means the chromatids go wrong. Non-disjunction occurs in these kind of patients, the women. So the non-disjunction and the significance in human, we know that the human chromosomes definitely have a different kind of an aggregation or a segregation. The chromosome segregation errors during meiosis are the leading cause of birth defects and miscarriages. Now, looking at the centromere, is a specialized DNA sequence of a chromosomes that links a pair of sister chromatids. Why should we know that point? Because there's a difference in the young and the old. The whole chromosome non-disjunction events are preferably associated with the increasing aneuploidy in the young girls. Even in the young girls, there can be aneuploidy, so we cannot forget that. and whereas the centromic and more extensive cohesion loss limits fertility in the woman's age. Hence, both types will cause aneuploidy. The other cellular activities implicated in declining oocyte quality is because of telomere. It's very interesting. The pink structure is called the telomere. They are the ends of the chromosomes. The telomere disappears over the age and becomes very, very less in the chromosomes. That's called a telomere shortening. Now, eventual exposure of the DNA, the ends of the chromosomes of DNA, they get exposed and are inevitable consequences of ongoing cell division and increasing the ages where we've seen there. The uncapping of the chromosome ends affect oocyte cellular function and reactive oxygen species. I want to emphasize that point, that bottommost chromosome, what you see there, has hardly any telomere. That means the DNA is exposed, they are all exposed to oxidative stress. So we should understand the older the woman, they have more of this telomere problem, they are more of oxidative stress. So can we do something about it? Once again, the telomeres, the physical ends of the chromosomes, are involved in control of chromosome stability, genetic integrity, and the cell viability. The telomeres are essential units that prevent the loss of genetic information. Hence, the older the woman, there is less telomeric activity and leads to chromosome defective. So the age, the inverse U curve of natural fertility that limits fertility in young and advanced age has been explained completely differently. They all have chromosome problems. So acting as a sort of biological clock that avoids early pregnancies in women with bodies not yet mature enough and in older women due to the advanced age. So can the ovarian aging be delayed by any pharmacological strategies? There is a view that hypoandrogenicity and the poor ovarian reserve, understanding the dynamics is important, though it is not being proved to be so beneficial. But let's understand that the androgens definitely decline with age. Androgens are necessary for receptor activities. The physiological action of androgens in the follicular development has been proved by several physiologists. And the androgen and the follicular recruitment happens because there's a synergism between FSH and androgen. What I'm trying to tell is the recruitment and selection, the androgen component is very, very important. The androgen receptor mRNA is correlated with FSH receptor in the granulosa cells. Thus, androgen augmentation of FSH receptor expression in the granulosa cell amplifies FSH effects on the follicular growth. This diagram clearly tells, it is from 2014 publication, by repeated cycles of androgen, there is an oocyte retrieval which may be better. So even if you give some androgen, it's not for 1 month and 2 months. You may have to give for 6 months, minimum of 3 months and maximum of 6 months. You'll understand some of these oocytes may be better, though the theory or the literature doesn't say all the time positiveness. Even if you're not using DHEA, you should use 25 microgram 3 times a day for at least 4 weeks before the start, or I would say 3 months. But one interesting factor is, when you do IVF in the older woman, you give for about 3 to 6 months, and even though the oocytes are less subsequently, you will find they're a little better quality oocytes than other people. But the testosterone level at the start should be at least more than 30 nanogram. That means when you start an IVF program, when you look at the testosterone, it should be at least 30 nanogram per deciliter. If you're given 6 months of androgen, and if you don't get testosterone about 30, then that oocytes do not really matter. It doesn't become good at all. So the only clue is to get the testosterone level by more than 30. I would say it's a good effect of androgens. So lot of studies have said control and DHA have come kind of improvement of the oocytes. But interestingly, Chimote, my friend from Nagpur, has published this in Human Reproduction. He has said clearly how the clinical pregnancy rates and the live birth rate were definitely correlated with the follicular fluid of DHA. Increasing DHA will give a better oocytes and pregnancy rate. Kuhn et al. Also have said in 2014, the low testosterone levels in women, the diminished ovarian response and implantation rate is a retrospective case control study. They clearly said more than 32 nanogram per ml has a sensitivity of 82% and specificity of 58%. So transient androgen supplementation significantly increased the embryo implantation rate and the clinical rate. But remember, look at the testosterone level of 30 nanogram per deciliter. Only then you will know that the response is better. So we have understood over the years how improving follicular recruitments are occurring. But 17 randomized control trial of Cochrane, as always, is not clear. But they said initially the DHEA has shown around improvement of 26% compared to 12%. But they said on removing the study to the bias, the increase was no longer seen. There was insufficient evidence. I always say literature is there. It is never proving to be anything particular. But when it comes to the individual point, I think you should try for at least 3 to 6 months. But remember, lesser than 20 nanogram testosterone, they're 5 times less likely to get pregnancy. I emphasize the point again, more than 30 nanogram of testosterone should be there. So Sej Kamal Sunkara has clearly said the same thing. Robust data from RCT have showed an improvement in live birth rate following the HA improvement, but the poor ovarian response is lacking. That means it's still not clear about the whole issue. But interestingly, what can we do in a clinical practice other than the androgen? We have to think a little wider. The PLAS study 2014 has clearly said oxidative stress induces. I told you about telomeric, the ends of chromosomes. The oxidative base damage leads to abnormal nuclear morphologies, and the telomere dysfunction is an important contributor, has been shown to accelerate telomere shortening. So I think whether antioxidants can also be tried. This is just my thinking, wild thinking, but there's no harm in trying that. But interestingly, very young people who have poor ovarian reserve, please understand they may have immunological aspects of infertility as well. So when somebody has all these chronic diseases like APLA, SLE, Hashimoto's, rheumatoid, etc., Crohn's disease, they go to GEC, they go to rheumatologist, all of them have autoimmune diseases and they all have poor ovarian reserve. They have higher implantation failure, higher abortion. So please understand, immunity will change the Th1, Th2 response as we know. That means a positive ANA test, is the immune system affecting the pregnancy? My answer is, to a certain extent, yes. The simple presence of ANA, however, indicates that there is a great probability that the immune system is involved in these pregnancy losses. The association is even higher when ANA is associated with anti-thyroid antibodies, even with the thyroid function being normal. That means please do ANA global, please do anti-thyroid antibodies in all these recurrent pregnancy losses and even recurrent implantation failure, even if the DNA system is not doing very well, because the antibody may attach to the invading embryo and the trigger an influx of inflammatory immune response will cause destruction. So can the ovarian aging be prevented by any other thing? A very interesting Chinese come out with all these kinds of a lovely article, and 2019 on Aging Journal has clearly said, of course, these are all to be discussed and maybe refuted. Reputation is quite high, although we do not know. But the oxidative damage products of DNA, protein, and lipid in ovarian stromal cells increase markedly with ovarian. Therefore, the antioxidant, is there any point in giving them? You can decide yourself, but I think simply giving vitamin C, vitamin E, N-acetylcysteine, and curcumin. Curcumin is what is used for every cooking, the yellow powder what we put, probably can be thought of. I'm just thinking very strangely today because I think there's no other, even the PRP injection to ovary doesn't really chromosomes. But if you look at the telomerase activity, what I explained to you, maybe these kind of grape seeds and fruits and vegetables, sea, wines, and etc. has some kind of a role in this telomerase activity. An interesting publication in 2019 also says about mTOR, mammalian target of rapamycin called as mTOR, regulates cell growth, metabolism, and autophagy, and they all are important in follicle genesis and oocyte meiotic maturation. So let's not give up on these telomerase reduction in older women and the younger women having some kind of epigenic regulators. Melatonin and resveratrol are potential autophagy inducers that may extend ovarian lifespan because they are once again connected to oxidative stress and telomerase end. The resveratrol, an important phytoantioxidant commonly found in grapes, mulberry plants, etc. They're all, I think, thinking wild today just to know there may be some action on this telomerase activity. Hence, there are several things trying to be improvising on this ovarian reserve. Can we prevent aging? I'm not sure about that, but these are the future younger research can be taken up in these kind of activity. To conclude, the take-home message is reduction in oocyte quantity and quality inherent in reproductive aging result in clinical subfertility and increased miscarriage rates in even very young girls along with the older women. An improved understanding of the mechanism involved in female reproductive aging is definitely needed. Development of biomarkers and treatment to predict the timing of age-related decline fertility provide the target point of therapeutics. My wishes from Manipal University, and I come from the state of Karnataka state on the west coast of the country. Thank you so much for the invitation and for your patient listening.
Excellent talk. Would Dr. Kavita Vapat would like to give some comments? Dr. Kavita?
Ma'am, I think Dr. Kavita ma'am has got stuck up somewhere.
Okay.
So you can give the...
I would say, Dr. Pratap, it was such an excellent way that you discussed about the ovarian aging, and especially about the damages that can occur about the shortening of the telomeres, then the role of the, as far as the androgens are concerned, and the implantation, and going to various as far as the natural products are concerned. So I was actually even wondering, because many of these people have started giving DHEA and pregnancies have occurred. But the other question was that these pregnancies, when they have occurred, they go on normally, you know, and one is not able to detect. Have we seen in the babies who are born that there is higher cases in which the abnormal babies are born? That is one thing, if any of the studies.
They have not really identified so much of abnormalities, but I agree with you, madam, the incidence of chromosome abnormalities will be definitely higher than a younger average age person. And that's a very well-known fact. But I was just thinking today, I brought in some new point of the telomerase activity because I found it very interesting. How we can probably diet modification we can try. It's not the ultimate in discussion, but there's no harm in doing some more research on that.
Yes, it is very impressive that whatever this older people thought of improving, you know, that giving them the fruits, then the giving up these certain vegetables, then the other tea, and the way you have enumerated in the various way that we can improve the implantation and the pregnancy. It was an excellent talk and very well delivered. Heartiest congratulations, very well.
Thank you.
We learned a lot, you know, every time when you deliver a talk.
Thank you so much. Thank you, ma'am. Thank you, everybody. Nandita, nice seeing you, and then all my friends are there, so thank you so much.
I've waited for your talk.
Thank you so much.
Super.
Yeah. Arulmai, Shaijas, Jyoti, Uma Sharma. So nice to see all of you. Thank you, Sujata, Anshu, and Raki for inviting me to Noida Society. Next time you should come in. We should be in person in Noida. Personally.
Yes, sir, definitely. We'll do it. We'll do it, sir. You are always a star of
everybody. Everybody.
But it's so nice that today, see me, Noida people have rich in material, rich in science, rich in the talent that we have had, and the richness of the speakers, you know, each and every, whether it was fetal medicine or other, I have thoroughly enjoyed and being a student again today. Thank you for the Noida and the excellent speakers who are the legends of their own field. Thank you.
Thank you. Thank you very much.
Thank you, Sujata.
Thank you. I would
Thank
like
you,
to
Doctor.
formally thank all my chairpersons for beautifully taking over and carrying forward the keynote by Dr. Pratap Kumar, who is always a pleasure to hear and always a pleasure to call him to our Noida Society. And moving on ahead in this program, I would like to hand over to Dr. Anshu to introduce the next set of chairpersons.
Thank you, Dr. Rakhi. And now I would like to last session of this day, that is panel discussion. For this, I would like to call our moderator, Dr. Arul Moji Ramarajan. And ma'am is a former head of the Department of Obs and Gynae Society, Church of South India Hospital, former consultant at Bhagwan Mahavir Jain and Santosh Hospital. And the area of interest is high-risk obstetric, vaginal surgery, the past president and the active member of the BSOG, and the GenVid faculty at the regional, national, and the international meets and CME, and edited so many papers and the monograph on anemia in 2007, and edited several acute maternal morbidity in 2011, contributed chapters in the FOGSI publication. So ma'am, now the floor is yours. So please, ma'am, start the session and introduce our panelist.
Thank you so much. And may I share my screen? Oh, can I get a little help for sharing my screen?
Ma'am, you need to put lower down in the center. There is a screen share green button, which you need to.
I did that.
And your slides need to be opened in the back end.
Okay, I'll do that. Just give me.
So then you can choose your slide.
Anyway, as the slides are opening, I would like to sincerely thank Dr. Sujata and team, Dr. Anju. Simply a marvelous session, and I really appreciate the timekeeping. And if you have engaged me in such a beautiful session, I'm honored. And in this session, where it's going to be a case-based discussion on near-miss situations, if there is going to be, yes. Why is it not coming? Yes.
Dr. Jain, can you help ma'am?
Have you opened the slides in the back end, ma'am?
Oh, I've got it.
Yeah, great. It's
got it.
It's coming.
Yes.
Sorry for the delay. So if in this discussion of 4 selected near-miss situations, which I have faced, if there are some messages, some take-homes for every participant in this meeting, and if that could save one mother in the coming days, I think we have got what we wanted, and the credit would go to Noida Society. So to begin with, let me introduce my experts.
Dr. Jain, can you please share the slides of our panelist?
Madam must be having it. Probably if we, Dr. Jain starts sharing it. Dr. Jain?
Yeah, it has begun.
Ma'am, you can speak.
Yes, I'm just, I'll bring it.
You can speak from what is there in the screen.
Okay. Okay. Okay, we have Dr. Shaijas, who's a chairperson-elect in Midlife Management Committee of FOGSI, chairperson, research committee. Oh my God, so many things. Shaijas, can we just let the audience read it?
No, madam,
and
please
can
go
we
ahead.
go on
Please
it?
go ahead.
Okay, then can I go ahead with the next? Yes, Dr. Nuzhat Aziz. She's from Hyderabad. Dr. Tejavati GV is from Bangalore. Dr. Jyoti Bhaskar and Dr. Sujata, but all senior experts from New Delhi. So can we move on to the presentations? I welcome all the experts and I'm waiting to hear from you what you would have done in the situation that I was in. First of all, now these are very direct, simple questions with an expectation of short answers. Dr. Shaijas, what is SAM?
Yeah. First of all, thank you so much to Noida Society and my dear moderator, Arulmozhi Madam, for this wonderful opportunity to be here today. SAM is, as many of you would already know, a severe acute maternal morbidity, a relatively glorified term of the term called near miss cases that we always used to use for the last 4 years. Now, this is a very promising alternative that has come up for maternal mortality rate over the last decade or so. Because as you all know, maternal mortality rate is reducing in number. So there might be many districts in India where there may not be a maternal death at all for months or so. So what do we look at and what do we learn? So if MMR talks about the tip of the iceberg, then SAM forms the larger base of that iceberg. And that would attempt to identify any amount of preventable risk factors related to managing an obstetric patient. Thank you, madam.
So near-miss appraisal has now emerged as the new yardstick to assess the quality of healthcare. What are the causes of near-miss? It's absolutely failure to follow protocols, making incorrect decisions, you'll see that down the line, delayed interventions, non-availability of material or expertise or ICU facility, and also a refusal to follow medical
Madam,
advice.
your slides are not seen now.
Oh. No?
No.
You have to share the slides again, ma'am. Yeah, it's starting to share now.
It's come, ma'am.
It is seen now.
Screen run. I'm not able to move to
Madam,
the next
just
slide.
click on the PPT.
Okay, I got it. Okay. So we are now on what is SAM we've just finished and why this happens. So it's essentially SAM to mortality. There is one small window and we'll have to work there to stop death and no woman should die giving life. So what is case fatality ratio? Dr. Nuzhat, please.
Thank you. A big thank you for inviting me to be a part of this panel and lovely to see you, Dr. Arul, after a long, long time. Now, the first question followed by the second question, case fatality ratio would mean the number of deaths that you would have in a specific disease over a period of time, over a specific period of time. And it means that if I have 100 people of PPH in a year, how many deaths did I have? So basically, a case fatality ratio would mean in a specific disease. Now, as Dr. Arul has put, it can also be a variety of scenarios that you can take. If it is in a near miss ratio, then you have case fatality ratio for that group of people. Or like WHO said, you can have maternal near miss outcome ratio and incidence ratio or maternal morbidity index and so on.
So this is actually a very sensitive measure of the standard of obstetric care. And just as a comparison, if you see here,
In South Africa, if there are 5 near-miss cases, 1 of them would die. As against that in India, with 11 near misses, 1 would die. But in the developed countries, so to say, 200 odd near misses, only 1 would die, which means that the care given, the interventions given have been so good that ever so many were stopped from dying. So we need to get a ratio of this size. So that's why we have case fatality ratios to say what's happening. And now going on to the case scenarios, the first case, first of all, expect the unexpected is the tagline. There was this booked 34-year-old 4th gravida, previous 2 cesareans, mild anemia and GDM, well booked, well managed. She had a planned repeat section at term. Hemoglobin and fasting blood sugar levels were okay. Now, with this, what problems would you be prepared for is one question, and what special measures would you take to avert an adverse event is the other part of the question. Dr. Tejavati.
Can you hear me?
Yes, yes.
Yeah, actually there's some problem. Suddenly the thing has gone out, my video. I will take a little time. Meanwhile, I'll answer your question, Dr. Arul. Since it is a repeat LSCS, the first thing problem I would encounter is entering the peritoneal cavity. Because of intra-abdominal adhesions, sometimes we may not be able to open the peritoneal cavity in the way we want. Sometimes you have a bowel or a bladder just below. The bladder would have been advanced, and then we may have a bowel just beneath the our incision. So to avoid injury to under the bowel or bladder, I would like to take incision as high as possible, opening the peritoneal cavity, so that you prevent injury to
would you take a vertical skin incision for that matter?
No, I would open.
On a low transverse, you would go high up to open the peritoneum.
Yes.
Now, before that, perhaps we are going to have some problems. Now, she is going to be requiring more blood. So what do you anticipate when you're doing a repeat section?
Concentrating on the problem on the table. Of course, previous sections we would like the blood to be arranged depending on her hemoglobin status. If it is something more than 10 or 11, we would reserve one pint, and we would make sure that she's a properly posted case with.
Yeah, got it. Everything done. So one more point I would add here is that extraction can also be difficult, as it is usually.
That is after opening the peritoneal cavity. I thought I'll just come one by one. One is opening the peritoneal cavity. The next thing is, the bladder may be adherent to the low uterine segment, and you may not be able to reach it. So
we got all your points, correct?
Yeah, bladder.
Dr. Arul, can I add something?
And then the extraction, of course, would be difficult. So I think using a forceps would be a better way of extracting the baby.
Agreed, Dr. Nuzar?
One of the things, just talking about adhesions, and I found it very useful, is the sliding test that I do. And it's basically an ultrasound, maybe prior to starting an incision, is to just put it onto the anterior abdominal wall and ask the mother to breathe in and breathe out. And if you can see the abdominal wall moving over the uterine wall, you know that the adhesions are not firm and stuck up completely to the uterine wall. And it has been a very helpful and a very valid, proven test which we can use. And
sounds very practical, very easy.
Very
useful too. So there were no and no undue bleeding in this lady. Her pulse and blood pressure were normal, and she was shifted to the post-op ward. Dr. Jyoti, would you expect anything to go wrong now that everything has sort of gone off well?
Okay, so thank you very much for taking me onto this panel. So Dr. Arul, once I have done this and the patient has gone to the post-op ward, Though one would hope that nothing would go wrong with this patient, because that's a prayer that everyone has, but this patient will need to be monitored in the post-op. Because such a particular patient can have because it's been a difficult surgery, we've had adhesions, probably the lower segment was very thin and we did stitch up, there may have been some extensions. So we can expect that there could be a post-op bleeding which could have taken place. So we need to monitor her very well as far as blood pressure is concerned, her tachycardia is concerned. Look for PPH if there's no bleeding extra. And also always put a hand on the abdomen to see that the abdomen is very soft. So monitor her well in the post-op.
Monitoring is the word. Now, 6 hours after surgery, patient is comfortable. Even bowel sounds have started appearing. Pulse rate 90 and blood pressure 100/70, not alarming at all. Normal temperature. Urine output satisfactory and oral fluids were encouraged. IV fluids were increased because there was this hint at a falling blood pressure. Could she be having a problem? As you said, some bleeding, or could there be some sepsis which is growing?
Okay, so what I would think at this particular time, it's already 6 hours that has gone by over there. So maybe I would first check whether we have given her enough fluids or not. Because whenever we have done a spinal, maybe they have not loaded up well, or she was very probably fasting overnight. So one is the fluid intake, definitely I would like to match. Then secondly, if the blood pressure has been falling down consistently, then I need to really think about, is she bleeding from somewhere? So maybe I'll ask for an ultrasound to be done at that particular moment to look whether there's an intraperitoneal bleed, or I even touch the abdomen and see that if there is any tenderness, there's any, I would say, area where I can feel a particular mass, because sometimes we may be landing up in such a slow growing over a period of 6 hours. Maybe I'm having a hematoma somewhere else in the abdominal wall.
Yes.
So I would like to actually investigate in these particular points for the patient.
Wonderful. Further 2 hours later, the same process seemed to be continuing. A rise in pulse rate and a drop in her BP, however small or slow. Abdomen was soft, bowel sounds were good, and all else was good. There was no extra vaginal bleeding. So would you do some tests, or would you ask for an opinion? Would you do that, Dr. Sujata?
Yes, now that we find that there's a further drop in the BP and the tachycardia, I definitely would ask for an immediate bedside ultrasound, and also send her blood tests to see the drop in hemoglobin, and also arrange for blood and all that to optimize her condition again. But most important, an immediate bedside ultrasound to try to locate, to find out the reason.
Yes, we did an ultrasound. There was some free fluid in the abdomen, but it was not really sort of quantified to say significant collection. And in a post-op situation, a little fluid in the abdomen is not unusual or abnormal. Therefore, it was noted. A second opinion was also sought from a senior colleague. And she said, continue same treatment. Not still comfortable. I was not comfortable, though the patient was. And a general surgeon's opinion was also taken, continue same treatment. So they said closer monitoring, and a higher antibiotic would probably suffice. Dr. Shaijas and Dr. Jyoti, do you have anything to add?
Dr. Shaijas, would you like to add something? Then
anyway, yes, please.
Please go on, madam.
Okay.
I think I would like to arrange for 1 or 2 pints of blood, depending on her hemoglobin. Maybe we should get ready with the blood products.
And even sepsis, we should start thinking about that also, because it's already on the 2nd of the day, 3rd. That if she is not picking up, is she going into a septic shock? So if there is a septic shock, then we need to look for the other factors also, that where exactly could be there. So are we getting past somewhere? So maybe there was a hematoma somewhere which we missed out, which we need to really
ultrasound did not show any hematoma or any localized emergency. It just fluid and an involuting or a well-contracted uterus and nothing else. Well, on day 3, after 8 hours, the general condition remained same, and the family was getting anxious because having, I had done the earlier cesareans also, and they said the earlier sections were not like this. Would you want to shift her to a higher center? Would you want to call any specialist? Or do something, doctor. So that was where I was. And what would you do? Would you transfer her to a higher center? Any of you? Or all of you?
Can I?
Yes, please.
Dr. Warning trigger, severe 60 here, hypertension, I would call hypertension mean arterial pressure 90 by 60. I won't really jump and call it hypertension. So, I mean, if I'm just putting myself in a scenario, I wouldn't have got alarmed except for the fact that there was free fluid, but the fall in HP was only 1 gram, from 11 grams to 10 grams. Maybe I would have repeated a CBP the next day to see whether the hemoglobin has fallen further. I mean, that's my concern. The second one is I would put it for the operation, don't suck it out very nicely, the amniotic fluid that goes in. And I have, no hesitation in putting in a needle and then just aspirating and seeing.
Some 5 days a bloodstained fluid. Would that tell you anything more?
So some of the times we can do a hematocrit for this blood, and if it is more than 50%, then it is a bleed. It can't be a collected blood.
Okay. Now we did decide on a transfer because our hospital where this section was done did not have an ICU and did not want to push things to get worse. We preferred an early transfer, and the family also preferred an early transfer. So, Dr. Nusrat, again, what is your transfer protocol? If you have to transfer, I know you are in a wonderful tertiary care center and you'll never need to transfer anybody. But if you had to operate in a smaller hospital and if you had to transfer maybe to your own higher center, what would be your protocol?
It depends on the kind of care that we have. If we have an ICU setup, then almost all the facilities we can have. We don't have a dialysis unit and we don't have ECMO. Those are the two indications that we transfer them out. But otherwise, we have plenty of facility to open her up or to see whatever needs to be done. So except these two conditions, these two indications, I wouldn't transfer. But if I am in a setup where I don't have an ICU, then I'm still a little uncomfortable in transferring her out without putting in a needle. If I get frank blood and my anesthetist is not willing to open, she doesn't have coagulation failure, her urine output is good, she's not in renal failure, she's not in liver failure. I mean, what's my concern to shift her out? So if in case something is worsening, then I would. So my early warning signs would be very, very vital. And if I find anything as a danger over there, that's my time to pick up.
I got it. Well, so in the referral hospital, the patient's general condition kept worsening and she was on ventilator support. Sensorium altered, abdominal distension coming up, and a further drop in hemoglobin. Blood products were being pumped in. So this was the situation. Dr. Teja, what would you do now? Would you want to open, not open? Dr. Sujata, please opine on the same thing.
Yeah, I think I would open.
Okay.
Because if there is some sort of oozing somewhere, the hemoglobin has come down and there's distension, I would definitely like to open.
Absolutely. So there's
same Arul, so same opinion here that since she's worsened and there is a drop in hemoglobin, I definitely suspect some bleeding inside and would like to open her up.
So it's either hemorrhage or sepsis again.
I would probably do an ultrasound again.
Ultrasound done. Abdominal distension and fluid increasing. Tap was also blood stained. So
yes.
So
yeah.
We opened and this would be our findings slide. Gross hemoperitoneum, uterus well contracted, retracted, uterine incision clean and dry, exploration of the abdomen and pelvis, rest of the abdomen and pelvis normal, abdominal wall bruised, inferior epigastric vessels area oozing that was ligated. It was not an active bleed. It was not an active bleed, but the gradual leak into the abdominal peritoneal cavity caused a huge collection in the abdominal cavity. So subsequent course in hospital, she was on ventilator for a good 12 days. She went into DICR, cerebral edema with patchy hemorrhage, etc., etc. All systems touched. 36 units of products, 6 sittings of dialysis, and then she went home well on day 21. Everything ended well, death averted. But my thought was, could I have averted the situation itself? So coming to this intervention without delay was important. Maybe I should have opened her much earlier and taken her to tertiary care for that. Good communication and documentation certainly helped me. Now coming to inferior epigastric artery rupture, this has been reported even after normal deliveries. Stretching open or blunt opening of a scarred abdomen, giving fundal pressure, whether it's at vaginal delivery or during cesarean section. Then of course pushing by the anesthetist at C-section. Blunt trauma, even in an RTA, the seatbelt trauma can also cause this, or vigorous exercise or laughter also can cause this. These are just sort of points to tell you that it's not so very uncommon and we'll have to keep it in mind. One more thought that came to me after all this happened and after we analyzed what we did, what we could have done, etc., is closure of peritoneum. Now, how many of you close peritoneum? How many general peritoneum? How many of you practice non-closure of general peritoneum?
I close the peritoneum.
I close.
Because evidence, literature says non-closure gives better results and less additions, etc. So I was following that practice at that point in time. This happened about 12 years ago, but I can never forget every minute of this situation. Okay.
But Dr. Arul, okay, one incident cannot be, but we don't close the peritoneum in our hospital. And I do agree that it is possible, these kind of bleeds. I mean, the bleed can...
They're rare.
Yeah, it's rare. But closure would have probably given a tamponade effect and
yes,
would have arrested that bleed much earlier and maybe it would have pushed us so far.
Somehow in our hospital we haven't done that, and it is basically a bleed from one.
With a slight drop in blood pressure during anesthesia.
I mean, picking it up. And say pick up.
Yes. Okay, case 2 is a very short, simple one following normal delivery. It's the book Trimegavida, admitted in active labor. Full-term normal delivery, mild PPH, controlled with medicines. And about an hour later, just before shifting, she passed a large clot. But then the uterus was massaged, etc., and she was shifted to the postnatal ward. 2 hours later, she got up to void and change pad and collapsed on the floor. Resident doctor almost fainted again at what she saw. Blood and clots and soaked sheets and sari. Pulse 104, BP 90/60, and the initial connect IV, etc. was done. The patient's mother was screaming, save her, save her, save her. Okay, bleeding continued. The consultant on call was called and she came. And the usual initial shouting happened. Why did you put her in the ward so soon? Get blood, call the anesthetist, shift her to the OT for emergency laparotomy, etc. So she was shifted because the junior did not have a word. Opened, no blood in the peritoneal cavity, uterus normal, very innocent, 20-week size, well contracted, retracted, both ovaries, everything normal, broad ligament normal, no hematoma, nothing. What to do now? Dr. Shaijas?
Yeah.
I want to step in now because this doctor...
Shall I?
Yeah, I'll change slide. So what to do now was this consultant's question, because she just didn't know whether to close and keep quiet, but she was continuing to bleed and go hypotensive also.
Yeah, yeah. Now, hemodynamically, talking about a hemodynamically unstable patient after a normal vaginal delivery who has been opened, and we have found that there is no other source, probably other than a uterus which went into intermittent episodes of relaxation.
Okay. So what?
Yeah, what to do next would probably depend upon the hemodynamic stability factor itself. If she is still
continuing to bleed.
Yeah, but you told that, did you say a contracted uterus?
I did.
Okay, contracted uterus and she continues to bleed through the vagina, you mean to say?
Yes.
Okay, fine. Now, one important thing to be ruled out is there any retained products or placental bits which are still remaining?
Okay.
Okay. And never forget, even after a normal delivery, the occurrence of some amount of placental adherence, where some significant portion would have been left out, and still uterus might appear to be relatively bulky and on the contracted side. It might intermittently go into episodes of relaxation, and on the whole, if you put together, the cumulative bleed might be very significant to hemodynamically deteriorate her.
Okay.
One possibility. So idea would be to, what to do now, once you have already opened the uterine cavity and then...
Could you do something further inside?
So can I add something over here? So in case she's bleeding like this from the top and there's nothing there, I would probably put a lithotomy and go down and see into the vagina.
Yeah. I would also put a speculum and see.
And there's a speculum, so maybe I have an extension of the maybe the cervical which is bleeding and causing that.
So this,
I would still like to do that.
Yeah. There is.
Yes, this short case is just to say that episiotomy is a very small procedure, but a very important one, and it should not be just left to a very, very sort of a junior person who is not yet adept at getting at the apex. And one suture definitely.
Yeah, but Dr. Arun, even by the very trained people also sometimes it's not just the juniors. We also sometimes maybe very deep, and we'll end up with such hematomas and
collapse. I took 45 minutes for suturing one episiotomy as an intern.
We can have prayers.
And no, it is all in the learning curve. And now when we are training youngsters, we'll have to be keeping all this in mind. Yes, I was Titus's shoes for this case, and when I went there, this is what I did. And
I think before opening, maybe putting a speculum down, ruling out, and then would have been a better.
That's exactly what is look before you leave.
Yeah.
Well, Dr. Arul, one small point that that samples for collection lab tests should be taken when we are shifting to the OT along with consents. And one of the bottles which does not contain an anticoagulation, you should look at it, invert it and see whether it is clotted or not. One of the major things that lands you up into a major problem when you won't get the results, you won't have anything, but just invert it and see, okay, and then you feel a little better, okay, it's okay.
So we move on to the third case, and here let's see what unexpected stuff happens. G2A1, 38 weeks, she comes in with mild labor pains. She's had a spontaneous abortion at 9 weeks, and this pregnancy has been uneventful till date. Dr. Nusrat, this is for you. 140/90 blood pressure at 2 a.m. headache. Is that husband problem, madam? Kya bhi nahi. 4 o'clock she vomited once, complained of upper abdominal pain. He said no, nothing. She ate some masala stuff, indigestion. You don't have to do anything urgently, doctor. Meaning, they were worried that we might do a section. So they said, no, doctor, she'll settle down. So would you take her symptoms seriously?
Yes, Dr. Arul, because I just want to tell you a little story. Way back in 2015, when we were evaluating, we had 14 cases of eclampsia over a period of, in 10,000 births. And then when we evaluated, it is this indifference to the light symptoms where we think, so what we have in our protocol currently is 140/90 and any symptom, without doing a urine albumin, we will give her Maxil first. Okay,
absolutely.
Just give.
So she goes into labor. Her blood pressure now is 180/110. You're very right in suspecting that something is brewing. Okay, so now would you leave her alone for vaginal delivery or go in for a section is one question. And what medication? Maxil you've mentioned. Would you put her on an antihypertensive also?
At 140/90, I would not have had put in. I would have just given her Maxel, but I would have sent in blood tests, the preeclampsia profile, which would include a platelet count, LDH.
180, 110 at.
Yeah. So at 180, 110, I would give IV labetalol for her.
IV labetalol.
Yes.
So
that's our protocol. We use 20 mg every 15 minutes, and no, not 15 doses. We go for 20, 40, 40, and 80, and
Well,
that's
older, I guess.
yes.
Older with it.
So we give IV.
I would say we started using labetalol much later.
Sure.
IV labetalol. So our protocol says 15 milligrams each time, every 15 minutes, and 15 doses, up to 15 doses. This is just to remember 15, 15, and 15 as a simplified version of it. We can give 20 milligrams. Yes.
Having said that, doctor, I have not read about it. Maybe I'm not familiar with that. We follow the standard protocol, which is available, whether it's ACOG or RCOG, 20, 40, and 40 and 80, and so on.
A maximum of 300 milligrams, yes.
A cumulative dose of 300.
We don't.
Maximum
What
single
we
dose
found,
of 80.
What we found, Dr. Saijas, is that when we go to 80, and we were not able to repeat on another dose, so we shift over to hydralazine. We do have IV hydralazine at that point of time, because the bradycardia sets in pretty significantly at this point of time. So that's what we do. We last dose, when we reach, we shift over to hydralazine.
Okay.
What specific counseling and consent would you want in this situation?
Communication and counseling is very, very important in such cases.
What consent?
I would like to call the husband and another person, maybe mother-in-law or somebody elder, who takes decision. So I would like to call them and explain the complications of severe preeclampsia, that she may have a convulsion, she may have an accidental hemorrhage, and she may have multi-organ failure, and then possibility of an operative delivery and renal failure. So I would explain each health syndrome, each and every complication this severe eclampsia is associated with. And I would like to also take high risk concern, mentioning all these complications and the possibility of admission to NICU, or the baby to NICU, and an ICU, admission, and the expected, cost also, because they should be prepared both, mentally and financially for a long
My God,
stay.
all the experts are experts in capital letters. When I'm flashing the answers, it's already done. Good, very nice. So what was done? She was given labetalol initially, then nifedipine, Magself, investigation as just discussed, sent. Patient was getting increasingly restless. She was even saying that she was unable to see properly. So it was an emergency section decision, and it was done. There was blood staining of the peritoneal fluid, grade 1 meconium. However, the cards were good. So far, so good. Now, investigation reports came as we walked out of the OT. And everything pointed to severe preeclampsia, and we were relieved that the intervention was in good time. About 3-4 hours later, in the ward, post-op ward, patient started bleeding profusely. Vaginal fluids were there, but the uterus was not so contracted. So some atony, and urine was blood tinged, some DIC. What was happening, we didn't really get to know, but some mishap is happening. Atonic traumatic DIC. What would you do, Dr. Jyoti?
Yeah. So this is an extremely, I think, an anxious moment for everyone, because a patient who has a preeclampsia impending, PPH is something they are actually really bothered about. So the main things that would come in my mind is she having a atonic PPH, or is she in DIC? Because severe preeclampsia is something that can lead to DIC. So immediately the resuscitative protocol has to be restarted for this patient. We will just see what the cannulas have been inserted. We need to have at least 2 16 or 14 gauge cannulas put. Immediately take the samples. The samples are going to go even for the fibrinogen levels. We're going to do a complete coagulation profile. Apart from CBC, LFC, KFC, the complete samples and cross matching. I would ring up immediately the blood bank and tell them that we may require massive transfusion protocol, so I need to arrange the blood. They should be there. Call for help. call for my colleague who's a senior consultant, inform an anesthetist, see that the ward boy at least is there to carry my samples from here to the lab and to get the blood. They should be there. Sisters, I would call the senior sister to be standing there, plus another sister who's going to actually keep the timing, as well as see how much of fluids we are going to be doing. Now, she's a severe PIH patient, so I may not be able to give her very fast fluids because that can be detrimental for her. So over here, a little fluids which can be there by the time the blood is being arranged, and also going to take care of the uterus. So all the uterotonics have to be started in this case. Since she's PIH, methergine is only one which I'm going to keep off. But apart from that, syntocinon to be given, misoprost to be given, prostaglandins to be given to control that. Till I get the reports of the DIC, whether the patient is in DIC, and then my resuscitation of
tranexamic acid for PPH management.
Yeah,
yes.
It has a prophylactic role also. This patient, probably before we took her, we could have given 1 gram tranexamic acid.
Timing is
because we could have expected, yes. And now also again, definitely we can get that.
So would you involve anybody else in the
Yeah,
management?
I did say we are going to call everyone. I think we are having anesthetists, we are consultants, we are going to be having the sisters,
the blood bank specialist.
Yes.
Yeah. Hematologist, yes.
Sujata, can you tell us about this NTP?
Another important thing I would like to add is documenting in this case, each and everything, whatever we are doing.
Everything, every case.
Documentation is very important.
Yes,
document.
Maybe a just going to keep on the timings and the amount of fluids being given, who came at what time, who was informed, because that is the most important part at the end. Suppose something happens to the patient, we are in a problem there.
We'll do it. We've done it. It's a good point for everybody. Dr. Sujata, something about transfusion now.
Yeah, so MTP is actually massive transfusion protocol. Every hospital has its own protocol because one thing we should remember that here the blood products are given. It's not whole blood, it's blood products, point 1. Point 2, there is a predefined ratio. Now, some hospitals follow the ratio of 2:1:1, that is the PRBC is to FFP is to platelet. And some follow the ratio of 1:1:1.
What do you follow?
And if we follow 2:1:1.
Yes.
And if you happen to have the blood reports, then yes, you can give the identical cross blood. But in case you don't have the blood available, it's always possible to transfer O negative blood. That is why actually O negative. That is why in any high-risk situations, it's always better to confirm in your blood bank whether they also have O negative blood in case of need. And it need not be cross-matched. It need not be cross-matched. Uncross-matched O negative blood can be given. And the platelets, the RDPs can be given. And FFP, of course, if you do not get your reports in time to see whether it is above 1.5, you can at least transfuse following the transfusion protocol.
Now, in this lady, we did follow the protocol in the ratio in which you have just described the transfusion. And we had to give her a little more platelets because her platelets were dropping.
Dr. Arul, can I add in?
Yeah.
Sorry to interrupt, but what we would do, our management would be slightly different. Each one can have different, but the minute we get SGPT and SGOT, transaminase is very high. We do check on coagulation profile as well as GRBS. These are two things that are very closely related to the liver. And when we find that we are having one parameter of a HELP syndrome coming in, we repeat the blood test of the entire profile every 6 hours, so that we pick up things as they are going. And then the transfusion comes in only when my PT INR is more than 1.5. So if I have platelets of 80,000, it's not a transfusion indicator, and that's how it goes.
It's not a trigger.
Yeah, because it just gets consumed the more we give.
Which will dictate what you will do.
Yes.
The level of your hospital, the facility level, that will also tell you when what to do. Right? Very nice. Very nice.
I agree with you. Absolutely. But she would be requiring, if I have to consider this patient to be transferred out, this would be a candidate. Last time you asked me which patient, because pre-eclampsia and a HELP syndrome, we really don't have much to fight against that disease process that goes in so rapidly. So I think maybe this would be a patient that I would be really worried about.
Yeah, I was going to ask Dr. Shaijas the same thing. Would you have transferred?
I think
Yes,
without a doubt, primarily for the want of better care. This lady where all
And
those.
now, Nusrat, I'll probably ask Dr. Jyoti or Dr. Sujata or Dr. Teja, because I think I should give them a little more time on this. Levels of care. Since we talked about ICU, what are the levels of care for a critically ill patient? A quick answer. I mean, this is just a run of things. We are already going beyond our time.
You have an HDU and you have a ICU facility,
Okay. So we have 3 levels. One is a regular ward. You step it up for an HDU, and you have an ICU. Once a patient is better in the ICU, you step down to HDU and then back to the ward. So this is very important for obstetricians, because we can't always go on hunting for an ICU bed. And in a regular ward, there is a certain level of care which is not really going to help if staffing is inadequate, monitoring equipment is less, anything, and specialists don't come there. ICU is way high for a person who's not that sick, and it adds also to extra risk and morbidity. And we may be wasting resource and depriving another very deserving patient of an ICU bed. So we need what is an obstetric HDU, and this is what Dr. Teja mentioned about. HDU is more woman-friendly in the sense she can be attended to by trained maternity staff, and labor can be managed if that was also happening. There's minimal disruption of mother-to-baby bonding, and it is all under your direct care. Whereas if you go into the ICU, you would have to listen to what the intensivist will be the king there.
Yes.
Of course, you have your say, but still, it's not like the field you have in the HDU.
But the HDU also has to be multidisciplinary. It cannot just be obstetricians. We will need physicians, we need an anesthetic support, and we need to be trained to that level. I think we need to be trained for the critical care.
Every senior or high-risk obstetrician should also be a little into being an obstetric physician.
So it's team of experts, I suppose, headed by the obstetrician.
So he needs you and a HDU is what I want to say. And the last case, which is not really an obstetric one, it's an anesthetic near miss, so it's slightly different. Teja, this is a G4B3 posted for electives, LSCS and tubal ligation. The spinal was patchy and she required GA. There was difficulty in intubation, there was struggling, there was a lot of panic, and 10 to 12 minutes of hypoxia. Finally, she was intubated at about 45 minutes after shifting into the OT, but her SpO2 was still 70%. What would you do?
Since we are the primary contact, I would counsel. I would go out and talk to the husband and the attenders.
Tell them what
about the situation, the problem of anesthesia.
You would go out?
No,
You're
I thought this is after the surgery. No, I was thinking this is after the surgery. No, here, of course, since the saturation has gone, I would quickly finish my section.
Yes, all experts, one word.
Yeah.
What would you do?
I would,
go ahead.
Yes.
Dr. Sujata?
Go ahead, yes. Now, I mean, I have to use the word perimortem cesarean because her BP has come down. But here we have to think, we have to think of saving the mother's life, even if the FHS is dropping. So we will go ahead because it will help in resuscitating the mother.
Shaijas?
Yeah, I think same opinion. Go ahead.
Dr. Jyoti?
Yeah, see the word when we're using perimortem cesarean, it means that impending cardiac arrest. So we are using either cardiac arrest or impending, and where your CPR is going to fail. That's what we're doing. But I would definitely talk to the anesthetist. They need help. 45 minutes is too long to intubate a patient. I don't know why they landed up with 45. They must have called the seniors. They would have been able to do one. But definitely I would tell them that if you're going to take time, I'm going to deliver my baby fast because I need a good survival, not just for the baby, but also for the mother's resuscitation.
This
It's
is
got to be a decision between the anesthetist and myself and try and deliver the baby as fast as possible.
Absolutely fine. This is what was done. I sent senior assistant of mine. Nusat, yes, open, not open. I knew you would open.
It's not a cardiac arrest yet. And
not a cardiac
arrest.
yes, so cardiac arrest occurs, I am going to dive in and take the baby out. But if it's not a cardiac arrest, she's basically struggling with either a failed intubation or a wrong intubation, or I really don't know. She needs help. But if we come close to cardiac arrest and to resuscitation, I'm going to pull the baby out. I do agree that I have the possibility of losing that baby. Okay.
Mother also.
But mother is always the priority for me. I mean, in our hospital, I wouldn't, if there is evidence of arrest, yes, I will dive in.
Because in this case, with the patient nearly sensing everything, she's got a heart, she's got everything. I may not be able to do the cesarean at that time.
And the evacuation might actually help the respiratory dynamics too, right?
Exactly.
In a term baby, definitely it will help.
Okay. Absolutely fine. So what I did was, see, this communication was important. It helped me a lot. I sent my senior assistant to go and tell the family that the cesarean was just about to start and anesthesia took some time. It's about to start because when I come in, when I enter the OT, the family sits there and expects me to come out in the next 40-45 minutes and tell them how it's, the surgery went off well, this, that, whatnot. So 45 minutes, if I did not go and talk to them, they would be getting anxious. So I sent somebody out to tell them that I was just about starting. And it's important to document the time of incision, which we normally don't have to do in every cesarean.
Yes.
And alert the pediatrician because it's a hypoxic fetus. So quick entry, extracted a flat baby, multiple anomalies. Expect the unexpected again. It was not resuscitated. It had one orbital cavity. That much of abnormality. It had multiple. Tubectomy was not done. Uterus was closed in a single layer, of course, emergency. A quick closure of the abdomen. SpO2 remained at 74. Patient was shifted to the ICU for continued ventilation. Very morbid. In the ICU, ET tube was adjusted. She was still hypoxic. On all supports, expert advice, ICU team, everybody came. And that much awaited cardiac arrest also came in. She was revived. High pressure settings on ventilator were used to recruit more alveoli into functioning. SpO2 improved to 84%. She did improve and she was extubated and discharged 3 days later. So all this drama happened because of an anesthesia difficulty. Okay. It was, as you pointed out very rightly, that intubation was faulty. It was a one lung intubation. Facing the family is the next issue. After all this drama, do you think the family is going to be calm and quiet? No. So, Shaijas, now you have to be the soldier.
Yeah.
Is she okay, doctor? Why so much time? Why is she still unconscious? What was the problem with the baby? Why did the scan not show the abnormality? You're the obstetrician, but you have to answer. You do both cesarean and family planning also. What?
One single thing which could have made the situation little bit more easier is if you have acquainted the patient with that anesthetist prior to the surgery. And that is something which we generally tend to miss, and we try to become the only face of a clinician which the patient and the bystanders know. So if we can just do that with a routine pre-anesthetic checkup for all patients, so that patient before entering the OT knows that there is such a patient from a different specialty who's going to give anesthesia and which can individually have complications. I think that can save you deal with all these problems that you mentioned.
Each one of you, I would agree that the anesthesia consent is a very cursory one. The anesthetist really doesn't go on to explain everything, particularly in a C-section.
No, I would object to this one because in our hospital, we do have anesthetist doing it and we have a sign-in procedure. When a sign-in, a patient will not be taken to the theatre without the anesthetist being there, introducing himself, telling him what he's going to do the procedure in front of the obstetrician. So definitely anesthetists is as much part as you are. We made it a protocol.
Okay,
Yes.
it is there. Dr. Nuzat, of course, again, tertiary center. I'm sure you have a protocol for that.
Yeah.
Yes.
One of the things that, I mean, we do have pre-anesthesia checkup as well as the sign in, but one of the things that that helps is to have a video laryngoscope, which is one important tool, a very life-saving tool in any institute. I know it costs a little bit, but then over a period of time, the amount of assurance institutes, because and this kind of, so I think they will also have a very huge amount of support if we can have this. So currently we have one only in each unit, but we do have.
I would like to add another thing, Arun. In elective cases, I think we do have the time and it should be sent that pre-anesthetic checkup. But emergencies sometimes, I think it's a little, dicey situation where the anesthetist cannot.
Yeah, can I just add? Most
Yeah.
of the, most of the emergencies that happen are patients who are booked with you. So all patients who actually reach term are potential candidates for a cesarean section. And there are many hospitals which actually do a routine pre-anesthetic checkup for all patients before you actually induce, because those are potentially
Even otherwise,
cesarean section patients, especially with the cesarean section rates that we are encountering. That's a very
they may need, but not in our hospital. I'm not in a
No, but even if they have a pre-anesthesia check, they're in the anesthetist to the patient, even if they have not seen them earlier. It's, as you said, at least I make them aware that there is another doctor in the picture.
Yes.
So now, as Shaiju said, generally the obstetrician is the one to face all this. But then, being an anesthetic near miss, the anesthetic should explain the situation and need for continued ventilation, ICU care, etc. Therefore, both should be involved in the subsequent management. The pediatrician will explain why the baby's situation was a DNR. Okay. So, forward. So our responsibilities here would be, we have to be the team leader, we have to communicate, document, and debriefing to the team, to the family and patient is very, very important. Incident reporting should be part of, your hospital protocol should be followed. And when we are communicating, you'll have to identify a spokesperson, avoid loose talk. You'll have to keep the hospital authorities involved, and also we should never miss a near miss audit. Near miss audit is very, very important. Now,
and I think just a point, I think both the anesthetist and the obstetrician should be on the same page. They should know what they're saying. Each one shouldn't be saying something different.
Together. Together. I know what he says, he knows what I say. And it's absolutely open.
Can I just add a point? I hope if you're not aware, there is a near miss confidential review that is happening in Kerala for the last 4 years. Okay. So not just the maternal mortality, but even the near miss cases, every month people are reporting and it is being assessed without revealing the identity of the doctor involved, and the review reports are being sent to the individual centers as well as to every obstetrician. So it's time, I think, we take up this and do it in every state in India, and which can really, really be a good learning experience.
It should start off even with one single near miss as a case discussion in the unit.
So monthly.
And then
so what we should do is monthly, you should, not many will be there, in a month, and it should be an anonymous discussion which would be highlighting what are the preventive points and where we could have been better. Otherwise, it delays the extrapolation of knowledge.
You will repeat the mistakes otherwise.
And most important is no blame culture should be there. We are not set here to put blame. We are set here to actually improve each other.
And almost always try to make it confidential, even if it is within
our own group.
Who's involved and all that. Better not come out in public and in a meeting say that it is this particular unit which managed this and end up in this problem and all.
No names.
It's confidential.
Now, so perimortem section, we may call this as a perimortem section in that sense of the term, though she was posted for an elective LSCS. It sort of became a PMCS.
Yes.
It's a life-saving procedure, etc., etc. And timely intervention is critical to maximize the survival possibilities for both mother and baby.
So I think only thing we need to understand in perimortem is that it has to be done only after 20 weeks of pregnancy. And the main purpose of doing the cesarean is to save the mother. Not the reason for doing a perimortem.
Very true.
So we need to understand it very clearly. Yeah.
Will include baby survival if the baby is still ticking inside and if you can do it in 4 minutes flat.
The 4-minute rule is there, that 4 minutes if CPR patient doesn't revive, you stop, and within 5 minutes you should deliver.
Yes.
But practically speaking, when you review all the literature, that is where no one can do it within 5 minutes. It's not possible. So the studies have shown that even if you go down to 10 minutes, the survival is not so bad. And one of the latest I was reading there, he says that we need to challenge this 4-minute rule to go on to immediately. The word that they used to use, as soon as the cardiac arrest is there, CPR has been started as fast as possible, as much as.
And rather than post-arrest, it will be a peri-arrest. That means you need to be prepared that this patient might be the one, probably in such scenarios, you might end up with doing it on a timely basis.
Dr. Sujata, what consent would you take to perform a PMCS?
Here it is actually a life-saving situation.
Not in this lady, because we have
so actually
consent for a planned cesarean.
In the perimortem cesarean section, the focus is on saving the life, so there is no consent actually required. Not absolutely necessary because you're focusing on saving the life of the patient.
So it is the only surgery, major surgery, emergency surgery that you would do without consent, right?
Yes.
No other department can boast of such a situation.
Yeah. No, but I think in a medical legal case, we might be asked, why did you not do it as part of the CPR?
That consent is not required.
Is not.
2 minutes off. Okay, somebody else may go and take it, but you cannot get an informed, written informed consent, which will kill her. So that's not essential is the ruling. And as Dr. Jyoti said, 20 weeks would be the cutoff to do a PMCS or PMCD.
Better for more than 24.
Yes. So less than 20 weeks, there is no aortocaval compression, so it doesn't help mother survival. Between 20 and 23, yes, to improve maternal survival. More than 24 weeks, potential fetal survival also gets added. Then be prepared for what may follow. Assault, mob violence, refusal to pay the bill, and litigation. Have you not faced this, every one of you?
Yes, we have.
I have faced, because I have faced these in these cases only. Anyway, so you have to have all the protocols: adverse event protocol, referral protocol, protocol to handle violent, volatile situations, etc., etc. So
the obstetrician starts feeling perimortem now.
Every patient is a potential whatnot. Okay, obstetrics is like that. Litigation. Now this is the last information slide. We'll have to be prepared. So I'm sure everybody has a professional indemnity. And important, you should not have a break of even 1 day. You have to inform authorities, hospital authorities or hospital lawyer of the possibility of a problem whenever you do have a near miss. Inform insurance companies of the possibility of litigation and keep those documents in safe custody in the office. It can't go into the general medical records department and then you go fishing for it. So with this, I would like to close the panel, and I hope there is something for each participant to take home. And my heartfelt thanks to all the panelists. Really wonderful performance, wonderful answers, quick answers. Great. Thank you so much. And once again, thank you, Dr. Sujata and team for involving me in this near-miss panel. I'm very honored.
Thank you, Arulmozhi
Thank
madam.
you. Thank you, Dr. Arul. Thank you for that.
So
excellent. It was really excellent.
Thank you, Dr. Sujata.
Oh.
Yeah, we've had a lot of take-home messages.
Thank you. The last slide also showed a man with his pregnancy. So he may also come into our... Thank you all.
I was just checking my abdomen.
Wonderful.
I hope next generation gets it.
Yeah.
Thank you so much.
Thank you, ma'am, for a wonderful moderation of a very important topic with our excellent panelist. With the last session, we come to the end of the first day of this 2 days of webinar. And on behalf of all Noida Obs and Gynae Society members, I would like to thank each and every one of you who took part in today's webinar. I would like to extend my thanks to our all eminent chairpersons and the wonderful speakers for their amazing lectures. And I would like to extend my special thanks to our great seniors, Sir Professor Arul Kumar Sir, Professor Kamal Baksi Ma'am, Professor Pratap Kumar Sir, Nandita Ma'am, Dr. Alpesh Gandhi Sir, and I will be if I will not include our partner, last but not least, I would like to thank PharmEd pharmaceutical team and a special thank to Dr. Jain for their wonderful support throughout this webinar. And looking forward to welcome you all again tomorrow with our everybody.
Thank you. Thank you. Thank you, everyone. See you all tomorrow.
Take care and stay safe wherever you are. Bye-bye.
Thank you.
Thank you, and log in tomorrow, please.